This is Transparency, a podcast by Gender Dysphoria Alliance, hosted by Aaron Kimberly and Aaron Terrell. Each week we'll be joined by people who have personal or professional experience with gender dysphoria and physical transition. We'll also discuss how our trans experiences relate to the concept of gender identity. Join us for a compassionate yet heterodox approach to the question of trans. Welcome to another installment of our special series on the Trans Health Summit. A note to say that if you are listening to this on a podcast platform, I highly recommend stopping until you can actually listen to it on YouTube. A lot of the audio in this recording is quite muffled and difficult to hear, so we went ahead and actually transcribed a lot of the questions and answers that happened inside this conference session, and that's actually in a lot of cases kind of mandatory even to understand what's being said is to read along. That said, because so much of this audio is quite muffled and kind of almost frustrating to listen to at times, I was very tempted to exclude much of it, but for the sake of continuity and just full transparency, we've left it all the audio intact. But if some audio is just too grating to listen to because it's all muffled and difficult to hear, feel free to skim past or just press mute and read along in the transcript that'll be on the subtitles on the screen in front of you. Again, on YouTube, I highly recommend not listening to this in podcast only format. And one other note, this is a longer than normal episode. We're pushing Rogan length at about 2 hours and 45 minutes, so it might be an investment, but it's very, very illuminating into how activism has completely infiltrated all corners of the professional medical institutions. Thank you very much, and without further ado, here's the APA.
American Psychological Association guidelines for the psychological practice with transgender and non-conforming people. And I will let each of my colleagues to introduce themselves, but I'm Rodrigo Aguayo, pronounced them. I'm a research scientist at Wilmot Walker Institute and one of the co-chairs. And all of us are part of the team that has been, the task force that has been revising the guidelines, and we'll be going into more details about the process of revising the guidelines. And one of the things that I do want to mention as we begin is we're going to go over the process itself of the revision, and then also share the current version of the wording of each of the guidelines. But we definitely want it to be more interactive. So as we go through that, we want to be able to answer questions and get any feedback from you all. Because one of the things that we definitely want to get is feedback on how to improve the version that we're working on. And we'll talk about other opportunities for it, but this would be a good place to start with that dialogue.
All right, thanks for hanging with us, folks. Turns out tech problems are an issue. So, but we got it, we're here. And I'm glad that you all are here and that we're having this awesome conference together. We're excited to share this stuff with you. The original guidelines for working with trans folks was published in 2015. And so part of what the goal of the guidelines, what we're really trying to do is talk to psychologists about what to do to provide culturally competent, developmentally appropriate, and gender-affirming psychological services. We also know that these guidelines, the guidelines and APA and anything that comes out of APA also gets used by other organizations. And so we're aware that although we are writing for psychologists and APA, that this is also guidelines that will go out to so many other organizations that look to APA for some of that guidance. They're built with the idea that this is not just for beginners and not just for advanced folks, right? But across the levels of experience that people might have, that psychologists might have, that we're really trying to write with all of those levels of experience in mind, which you can imagine can be tricky, right? To figure out how do we speak to all of those different levels of knowledge. In terms of the evidence base, we are looking at existing literature and professional consensus and opinions on best practices. However, we also know that literature, as we've seen today in all the various talks, is skewed, is flawed, is missing various populations. And so as we're pulling from the literature and putting in all these pieces to say what is the state of our science, we also are aware that our science is flawed and limited. So we're holding all those complexities as we're moving through this process.
So, and the guidelines itself are to be used in partnership with other treatment guidelines and standards of care, such as the one by the Endocrine Society or the WPATH standards of care. So in a way that they're supposed to complement each other, or that's one of our goals. And usually, they were scheduled to expire. I mean, the guidelines for trans people and gender nonconforming people were scheduled to expire in 7 years rather than the 10 years that the usual guidelines take, because the knowledge base was developed rapidly. So that's why we're doing it in a different time than the other APA guidelines. And just to go over, like, there's when it comes to the APA process, there's a difference between the standards and guidelines, in which the main difference is that guidelines are more aspirational, and while standards tend to be like more or less like rules to be followed. So in this case, even something to keep in mind, even in the language that we're using throughout the guidelines is more aspirational in nature rather than directed, let's say. And another difference between APA has guidelines for psychological practice and guidelines for the treatment guidelines. The main difference between those two types of guidelines is the treatment guidelines focuses on specific diagnosis, while the psychological practice guidelines focus on specific population. So these guidelines in particular is focused on the transgender population.
I'm a little bit taller. So there's only 4 of us here today at this particular conference, but this is an 11-member guidelines task force. And there was this intentional process of considering who would be on the guidelines task force, having people from all across the United States, having the majority of the members identify as trans or gender diverse, with a range of gender identities across our group, and a range of ethnic and racial backgrounds, with sort of purposefully making sure that different voices are at the table. Our work began in the summer of 2021, and there's planned completion in September 2025. So this is a pretty long process. It's a very iterative process. It's been complicated by what's going on, the reality of like the political situation and how that sort of interfaces with the research and how we're talking about that. So, you know, we have our own process of developing guidelines through revising it, but also there's going to be these phases of then gathering outside professional feedback direct to what has been written. And then there's going to be a process of community feedback, both going to particular stakeholders, and we're going to have an open period where people can leave comments. And today, at the end, when we have Q&A, we're going to be writing down what you tell us and sort of thinking about, you know, how we can be intentional and make sure that everything that needs to be in the guidelines is going to be in the guidelines.
Hi all, Dr. Jake Eliezer, he, him pronouns, and I'm going to be talking a little bit about the feedback process. So as Elliot mentioned, this is an iterative feedback process that's going to be happening continuously over the course of the guideline development. This process is going to specifically include a 2-month public comment period. We're hoping that that's going to be happening in August to September of this year, so please be aware of that, be looking to APA to get notifications about that. That's when we're going to be doing our broadest public comment collection period. Anybody can offer comments. They don't have to be a psychologist, they don't have to be an APA member, anyone can offer a public comment during that period. We're also doing community feedback sessions, and so those are going to be targeted to make sure we get a diversity of voices and feedback from specific members of the trans and gender diverse community. We're going to be doing feedback during conferences, so we did this at APA and at WPATH last year, and we're hoping that this is going to be an opportunity for that as well, so we really encourage you all to please ask those questions. Is like something stuck in your craw about like the last set of guidelines? We want to know about that. Because it's really important to everybody on the team to make sure that we get this right. That's why we're taking the time to do it. And then the last piece is APA stakeholder group review. That'll be an aspect of that component as well. We'll be asking folks who have specialized expertise across trans health to offer specific feedback in areas of the guidelines as well.
We're playing a bit of musical chairs. Last time we did this at WPATH, we each had a little microphone and we just got to sit there and chat. And so we'll bounce back and forth. I also realized that with all the technical stuff, I came up here and just started talking. But I'm Jay Betta Garcia. My pronouns are they, them, and I'm happy to be with you all today. So a look at our current draft. There you go. So we have a few guiding frameworks that are cutting across all of the guidelines that we're going to be sharing with you today, and those are intersectionality and minority stress. And so as we've heard at this conference quite a few times, nice reminders about intersectionality, not just the intersection of identities, but the intersection of our oppression and our lived experiences, and where we intersect with our privilege and our oppressed parts of who we are, but also the way that power and structures inform our lived experiences. And then minority stress, we know that because of intersectionality, because of the stressors that folks face depending on their marginalized identities, right, we have different kinds of stressors, we have different kinds of health outcomes, and so that is, minority stress is its own section, but it's also woven through, both of these are woven through the entire structure of the guidelines. We also have a deeper inclusion of non-binary identities than we did in the 2015 version. We're also using trans and gender diverse rather than trans and gender nonconforming. We know that language changes at a rapid rate, and so this is kind of where we're at now. This is our spot, but I'm guessing that in 7 years, when these get updated again, it will be different, right? So this is kind of our best catch-all for our terminology for now. We also are intentional about recognizing the role of the historic harm that's happened for trans folks and non-binary folks and gender diverse folks within the psychology profession and outside of it. And so really not shying away from it and not running from it, but being intentional and saying, hey, this is the state of our field. This is what psychology has done to trans folks. And here are some ways that we really need to think about moving forward. So yeah, that's a big piece of what we're doing as well. So a look at our current draft. So we have 5 domains, and within each of these domains, there are various guidelines. And so we'll share each of those guidelines for each of the domains, but these are the main 5 that we have going on for now. So we have foundational knowledge and awareness. So really making sure that people have the base level of what they need to know about gender and trans folks. Minority stress and resilience, and here we'll unpack this a little bit more. But really this intentional focus on resilience and joy and not just all the harmful things, right? We have a lot of damage-centered research happening, and so how do we also center resilience and strength-based approaches? Lifespan development, as you can imagine that the current legislative agendas across the country that we've been hearing all about, lifespan development is tricky to write about right now when so much misinformation is happening. And so we are digging into the science. We are being very careful with this area to make sure that we are presenting gender-affirming care the way it needs to be presented across the lifespan.
Okay. Did you hear that? So basically they're saying we need to be very careful with the science to make sure that gender medicine is presented the way it needs to be presented, right? Like basically it's important that the narrative is shaped in the way we want it to be shaped, is essentially what they were saying right there. Is that what you guys heard as well?
Yeah, and a brief acknowledgement that the science is quite poor. I want to take advantage of the fact that we do have a pediatrician here. So it's my understanding that in order for something to be called guidelines, it has to follow certain criteria. And one of those criteria is that they need to do a systematic review of the evidence. Is that correct?
Well, I think it depends somewhat on who you ask. I think there certainly has been an effort in the last couple decades to ensure that medicine is based on evidence, right? And evidence-based guidelines have become very much what we try to do as much as we can. So, and then there's standards of evidence, right? And so there are ways of determining whether what purports to be evidence actually meets certain standards. So I I agree with you, Erin, that it seems to be that what they're saying is we'll look at the science and it is flawed and limited, but that doesn't necessarily need to keep us from drawing conclusions and moving forward. That was my impression of what they said.
Mm-hmm.
And even in the 5 domains that they've started describing so far, it's clear that there's an ideological lens in that, just because of the language that they're using. They're using words like intersectional and really prioritizing this concept of lived experience over science. Like framing science as science is a part of an oppressive system. And what really matters is lived experience. And so we want to kind of apologize for the science and the damage that science has done in the past, and we want to prioritize the lived experience. So there's already that framing, right? Which is a very much a critical theory or queer theory framing.
Mm-hmm. Yeah, big emphasis on oppressor versus oppression, and yeah.
Mm-hmm.
And along similar lines, when evidence isn't available, they rely more on, as Diane Aronsoft said, clinical experience, right, or consensus, as opposed to actual data based on studies. So,
and the clinical expertise is now filling up with people such as these task force, right? These are, probably 20 somethings, maybe early 30s. Clearly their perspective is very much one of, critical theory. And those are going to be the experts, or the clinical experts, weighing in the absence of the evidence, are very, ideologically minded.
right.
Yeah, and I wonder if that's part of why they're not terribly concerned about the low quality of evidence, because when you frame everything through the lens of critical theory, which devalues science anyway, because if you see science as just a tool of the oppressor, then it's almost immaterial if your science is flawed, because they're trying to downplay the importance of science anyway. If they're not prioritizing science as the guiding principle, they almost see it as a thing that gets in the way of doing social justice work.
Right. Or something that can be used as a tool. Like if it's good, if it's in their favor, then it's good and it can be used. But if it's not, then it's disregarded and it's in the way.
Right, which is why they, I guess, made a point to say that the majority of the members on the task force identify as transgender or gender nonconforming, because that apparently, having that perspective is more important than, having a strong basis in science, right? You need that lens in order to get the appropriate outcome.
Yeah, and later on in the talk, they kind of go quite into detail with that, almost kind of not really arguing, but one going, we're relying on the, this is about science, it's not about us, it's about what the evidence says, and then the other one's saying, yeah, but we know the evidence is flawed and it's basically, historically oppressive, and then they're kind of like saying different things at the end, but like kind of almost going into what we're talking about right now, but kind of contradicting each other. I don't know. It's an interesting session. Yeah.
Do they go into at all? Because they touch on the fact that they're saying that the field of psychology has done harm to the trans population in the past. Do they ever kind of go into any depth and explain what harms they mean exactly? The
implication is just gatekeeping. Is that
do they ever spell
challenging
that
somebody?
out?
No, they do not. It's supposed to be like later on in the session, I ask the question about basically, is there going to be anything that's going to ultimately be able to let clinicians, an actual roadmap for assessment, and they're very clear that basically what I'm describing is gatekeeping, and that's completely affirmation is it's built like through the whole 19 guidelines right here, and they'll go into more detail about that as well. But basically, if it isn't just about immediate affirmation, then they didn't take it into consideration when writing these guidelines. And so they're very clear that that anything that isn't just believing somebody is what they say their gender is and then helping them access whatever medication they want in relation to that gender, anything other than doing that is an act of transphobia, is what, kind of spoiled the whole. Not really. I mean, I guess we kind of suspect the framework here, but before we went, I was going to say something else about something that they were saying in the beginning there that I wanted to call attention to.
Well,
It might
while
come
you're
back to
thinking
me.
of that, I just wanted to call out one thing that I noted that they mentioned is that they're going to apparently open things up for public comment. And so your listeners may want to watch for that. He said in August and September of this year, maybe via the APA website, that would be a good opportunity to weigh in if people
Nice.
have
Very good call. Very good call out there. Okay. All right. Should we just crack on?
Sure.
Yep.
Clinical practices, including assessment, therapy, and interventions. What a cute dog. Welcome. And then also education, research, and training. And so across these 5 domains, we'll get into the various guidelines that we have in each of these. Thanks.
All right. So our first domain within the guidelines, this sort of starts off the whole document, is foundational knowledge and awareness, exactly what it sounds like. So the first guideline is, and I'm going to read all of these for accessibility purposes. Psychologists respect the gender of all people and do not pathologize transgender identity, gender diversity, gender fluidity, or gender expression. And so some points included in this guideline would be the recognition of gender diversities as part of the human experience, and that clinicians are treating the problem that a patient brings in and not their identity. So if you've heard the term trans broken arm syndrome before, I know a person comes in for a broken arm and they're like, ooh, how's that related to being trans, right? That can crop up in psychology as well. The second guideline is psychologists understand TGD people are diverse and recognize the intersectional way that gender is experienced. So that gender is a non-binary construct that labels, like has been said before today, are widely varying, they evolve, and they are understood in a particular cultural context. And so to think that one cultural context, knows everything about gender and it's always going to be that way is just not true. Gender intersects with other identities and structural systems of power, such as race, ethnicity, ability, etc. And therefore, the solutions for trans health disparities include recognizing overlapping structural oppressions. The third guideline is psychologists practice cultural humility by recognizing the limitations of their knowledge regarding TGD care and engaging in learning as an ongoing process. So this is both that clinicians should strive toward sort of the classical cultural competence, increasing your knowledge of TGD people and their care needs, being connected to those communities, but also what happens when we don't know everything, which is gonna happen, right? And how do we respond to that in a non-defensive way, in a culturally humble way, and recognize a person's lived experience. The fourth guideline is psychologists recognize the historical legacy and ongoing harm of pathologizing TGD identities and commit to providing gender-affirming care. So this is a response to what Jay was mentioning earlier, the harms towards trans and gender diverse people in the field of psychology. So for example, gender identity change efforts, or popularly termed conversion therapy. Professional organizations like the APA have recently released resolutions and statements sort of condemning gender identity change efforts. So how do we repair those relationships with trans communities and commit to providing effective care that doesn't harm our clients?
All right, so next we have the minority stress and resilience guidelines. And so here we have 4 that we've outlined, really thinking about systemic factors, distal stressors, proximal stressors, and then also resilience. So I'm going to also read them. So psychologists recognize how systemic factors and socio-political contexts influence mental health and take steps to ameliorate structural stigma. And so I want to make sure that we call in our psychologists and our ethics of advocacy and of pushing against inequality and systemic oppression. And this is where we're doing it, right? So we're saying, hey, we know that the lives of trans folks are affected by systemic factors. We know this to be true. We also know that sociopolitical context matters for our mental health, and psychologists have a role to play in helping to ameliorate some of the structural level stigma. So here we're really trying to call in our psychologists to be advocates, right, to push for this change. We also know, or psychologists recognize, the role of distal minority stressors that impact the mental, physical, and psychosocial health and well-being of TDG people. Right, so here we're thinking about discrimination, victimization, prejudice, the interpersonal pieces that people experience that we know affect health, mental health, and psychosocial outcomes. The next one, psychologists recognize the role of proximal minority stressors on the mental, physical, and psychosocial health and well-being of TGD people. So here we're thinking about the proximal stressors, which are when we internalize all that negative stuff that's happening out there, and then we internalize it and think and have this shame response, right? Concealment, feelings of if I go into a space, I'm going to be rejected, expecting rejection. So we know that these proximal stressors, when we take on what exists in society, we take it on for ourselves, that it really negatively affects our health. And so here we're really thinking about how psychologists can notice that and help to ameliorate some of those pieces. And finally, guideline 8, psychologists recognize the unique strengths and resilience of TGD people and take steps to bolster resilience and positive outcomes. So here we're really thinking about how do we move past this deficit, damage-centered narrative about trans people and folks pitying us or think, oh, every time I think about trans folks, all I think about is the pain and the trauma and how hard it is to be trans. Like, hold on, there's also a lot of joy. Like, I love who I am, right? And I have a lot of euphoria and a lot of joy. And when we can sit with community and be in community and not be bogged down by the first 3, right? That we have lots of joy and resilience and resistance against these oppressive systems. And so really making sure that psychologists are not just using a damage-centered framework, but really thinking about our joy and our awesome narratives that can exist when everything else gets out of the way.
So the next set of
I think we should just kind of unpack those two domains there that they just went through. The first one being foundational knowledge and awareness, and in there they kind of basically answered those questions that you had, Aaron. It's like, what are these harms that they're referring to, and anyway, but they're basically saying that, and also in the minority stress and resilience, in both of these, they're basically just saying that psychologists will be queer theory activists. That's essentially what these guidelines are.
And they're also saying, they come right out and say they will commit to providing gender affirming care. So as that's currently conceptualized, I mean, you just take everybody at their word. So right there, that's what you're supposed to do. So it's really hard for me to square that with the role that I think of what psychologists do to try to step back and think about the whole person and what's in their best interest within a context.
And right here, the do not pathologize gender. Right there in that very first sentence, they're basically saying, do not discuss gender dysphoria. Because that's what when people talk about pathologizing transness or pathologizing gender, they're talking about discussing or addressing gender dysphoria. And that's what they're immediately saying, this is about somebody's unique, beautiful gender identity and not about any sort of psychological condition they might have. So, right, I knew that my question was going to be just completely contradictory to everything that they're already saying in here, but I had to do it anyway.
And
Sorry,
just that it's so deceptive and sinister too, to imply that anything other than completely aligning oneself with queer theory is somehow a harm and a violence against trans people, as if there's no other model for social justice and there was no such thing as compassion or social justice prior to the 1990s, right? Like, unless you believe in this orthodoxy of ideas called queer theory, you're a bigot. And they're weaving that into guidelines of professional practice and federal and state and provincial laws, codifying queer theory into these things, and the implication being that unless you fully buy into queer theory, you're therefore a hateful bigot and doing harm to somebody. It's an optional academic discipline. I mean, you go to university, you can choose to take queer theory classes or not, and it's alarming to me that it's no longer considered optional anymore. It's now mandatory education for everybody.
Right.
That shift is so fascinating, how that happened.
Yeah.
I also find it so baffling as a physician, because what I find sometimes is young people, I have a patient sitting in front of me and we don't have any common ground, right? They come in with this idea of who they are, and I don't even know where to start to question it. And so from my perspective, I'm not a surgeon, but, obviously a lot of these surgeons that perform top surgery or other gender affirming surgeries require a letter, right, from a psychologist, right? So they assume that the quote unquote diagnosis is going to be made by the psychologist, and they rely on that. So, but by these guidelines, there's no diagnosis, right? So what I keep wondering as a physician is, where's the diagnosis made? When does that happen? It's not by me, because I don't even have a common ground, sometimes when, I see kids. So when young people come in and they say, I feel like I'm born in the wrong body. I don't know what to do with that, really. Anything I say, we just have such a different view of how this all works. And so maybe I send them to a therapist or a psychologist, and if these are their guidelines, I just don't see how there's any sort of differential diagnosis as we would typically do in medicine, or any sort of discussion at all. So where does that happen?
Yeah, because you're right, in any other area of clinical practice, we always see greater clarity and certainty about diagnostic categories, right? Because we don't want to make a mistake and make a misdiagnosis.
Right.
And in a lot of the checklists that different organizations like Rainbow Health or the Provincial Health Authority in BC, they have a checklist of things to go through when you're doing a hormone readiness assessment. And they do, on those checklists, mention looking for that differential diagnosis, right? Looking for, and they say it's rare, but they say looking for those things that could be mistaken for gender dysphoria. But if you don't know what gender dysphoria is, and you have no certainty or clarity around that, how are you supposed to know what it isn't? Like, you need sort of these clear delineations to do a differential diagnosis. Yeah, I've seen patients that were very clearly psychotic, and I can't give any further detail because it would be identifying, but it's very clear psychosis. It was a very clear delusional thought pattern that led to them wanting to change sex. But it's how many of those kinds of things are being missed because everyone just wants to affirm and take people at their word.
Right.
Yeah, and trying to screen and something like that out according to the new guidelines would be essentially discrimination on the basis of mental capacity or something along those lines. Like any time that you're trying to address gender in, as they call it, a pathological way, that's a problem. So looking to screen out that, looking to find out if a person has gender dysphoria is pathologizing that person.
Yeah.
And so it's like, so there's nothing like, it's just but I wanted to, I was reminded what I wanted to go over is when they're launching this, the guidelines, one of them says that that they had to write these to all the different knowledge levels, right? And they're like, so you can imagine how difficult that would be to speak to all the different knowledge levels within the psychological field. What they were actually saying is different levels of belief in this system, right? Different levels of faith in critical theory, essentially, right? So it's not about who has how much knowledge about this. It's how much faith do they have in the affirmation only and the gender, blah blah blah. Exactly what you're saying. Basically, feel like you have a completely different perspective than the patient that you're seeing, and that's what they're speaking to in the guidelines. Is like we know that there's basically this worldview, that this very, very recent worldview that a lot of young people have adopted, and they're basically saying this is the right way to do everything, and we have to make sure that the people who are still grounded in reality know the new,
Right.
know that words no longer mean anything, and yeah,
Right. Get those older people up to speed. Right.
right,
With,
exactly.
not familiar with queer theory. Right.
Yep. It's a measure of faith. All right, here we go.
Okay. So the next set of guidelines we're going to take a look at are the lifespan development, having input into every other set of guidelines that are being developed. And so we are aware of the attacks that are happening against our trans youth in particular right now across the nation, and are trying to be really intentional in the way that we write these guidelines that are going to support the advocacy efforts and the work of things that needs to be done right now. I'm going to read these as well. So guideline 9, psychologists appreciate the unique impact of developmental stages and trajectories on TGD people across the lifespan, and integrate that awareness into the care that they provide. So this is really just kind of being aware of development, and not just in terms of chronological age, but also thinking about identity development, all the different aspects about human development that intersect with the experiences of transgender diverse people. Guideline 10, psychologists appreciate the unique experiences of TGD people within the developmental stages of childhood, adolescence, adulthood, and older adulthood, and integrate that awareness into the care that they provide. So in this guideline, we'll be breaking down into these different phases of these different developmental stages and providing more detailed information in each of these areas. Guideline 11, psychologists strive to understand the interactions between gender-affirming care, sexuality, sexual and romantic relationships, and sexual health. We felt like it was really appropriate to make sure that we were addressing sexual health and pleasure and sexual identity development, and felt like the lifespan development sections where this really had the best home. Guideline 12, psychologists seek to understand how parenting and family formation among TGD people take a variety of forms. One of the things that we really wanted to make sure that we included in this round of guidelines was information not just for parents of trans people, but for trans folks who are parents as well. And then also speaking to this aspect of friend-made family. So whether children are involved in your family or not, that's valid in their space, and that psychologists need to be aware of family systems that are unique to transgender diverse communities. Guideline 13 is psychologists recognize the importance of supporting parents of TGD people and integrate family support into the care that they provide.
Yeah, thoughts on lifespan development? You zoom through that.
Well, I just find it infuriating as a pediatrician. The way, I mean, when I think about transgender kids, the most salient part of that to me is that they're kids, not that they're transgender. And they're just seem to be assuming that from the time they're born, they're transgender, and we have to look back and sort of guide them through and make sure that they get to be, get to their transgender adulthood. But I don't see it that way at all. I think the most important thing is that they're children and young people, and that they should be looked at holistically in the context of their whole environment. And, especially since they also stress how gender is fluid. So again, they talk about it in some ways, as in these guidelines, as if it's a thing, as if it's an identity that you're going to keep your whole life. And yet at the same time, we heard many times during the conference how fluid it is, right? Aaron Soft's gender web. And so again, that contradiction keeps coming up. They can't have it both ways. And again, we're talking about children. I mean, the main fact about children, from my perspective, is that they're growing and changing and developing. And we should protect their ability to grow and change and develop in whatever way makes the most sense for them, rather than directing them in a particular pathway because we have some we're taking this perspective, we're imposing this perspective on them. At least that's how I see it.
Yeah, I'm curious what they mean, when they talk about developmental stages and the impact on their gender, because I mean, Zucker, for example, is a developmental psychologist who was seeing kids with a developmental perspective, and recognizing that gender identity development happens over time and isn't fully consolidated at a young age, and so that was the premise of the watchful waiting approach with children, is until their identity is fully consolidated, we don't want to prematurely try to solidify that for them. So I would say that is a developmentally appropriate way of working with children. I'm very much under the impression that's not what they mean in these guidelines. So I'm really curious how they see, developmental stages relating to gender identity, because I mean, like a 2 or 3 year old is going to base their gender categories on very sort of general stereotypes. And then as they, and I think it makes sense to me, if a child is, let's say, a gay boy who's naturally very effeminate, it makes sense to me that at that age, a child might be confused about which sex category they belong in, because their sex categories is based on stereotypes. And they might see that, well, I am more feminine and I do like dancing like the girls and I do like frilly things so I could see how that mistake might be made in that categorization error at a really young age. But as we get older, we start to integrate more complex information into that concept of gender identity. And I think that's why, the vast majority of time, by the time someone reaches adolescence, they shed off that misunderstanding. So, I mean, that I think is a sound way of looking at the developmental stages and how it might impact someone's self-perception and where they place themselves in sex-based categories. So I hope that they unpack what they mean by developmental stages a little bit more.
They don't. They go on. Yeah, go on.
No, I was just going to say one important developmental stage is puberty, right? Which this particular approach often blocks because it's considered to be traumatic. So
yep. Yeah, when they talk about the developmental stages, they're clearly saying, so you've got this trans person, so just be aware of the unique experience of being trans while going through these it's like the transness is static, essentially, is how they're phrasing it, right? And then it's just like, how is this person, based on this age, how are they impacted by, I don't even know what they mean, but it's basically like, be aware that this trans person is going to have a different experience of life at these different stages of life, but their transness will be the same. Like it's very, yeah, it doesn't make much sense, and they don't actually say what they're supposed to be looking for, what they're supposed to know, because they've basically gone through and just obscured everything that was that would be valuable in a guideline, right? They just it's just all obscured into just activist speak.
Yet the other thing it seems to do is to put gender in the forefront of the appreciation of what's happening to a child or young person as they're growing up, and I'm not sure that that's really, I mean, that certainly may be true for some children, but I think that it's pushing it forward more than might be true for the, for many kids. And, it's like asking a kindergartner, well, what's your gender, right? Like, is that really something we want to do? Is that really something we want to put forward as the most important aspect of who they are? When that
And Aaron Saft says yes, that you should be asking every child for any reason you're interacting with that child about their gender identity. Like, just plant that seed. This next section is just the most it's so very clear that they have no idea how to do this, because the point is to obscure anything that's actually clinical and to just insert activism, and it couldn't be more clear than in this section here. All right, so let's go on to clinical practice, assessment, therapy, and intervention. I have a note here that we should compare this to version, the last version, because that's what they seem to be trying to apologize for. And I did not bring that up ahead of this. We'll link to it in the show notes, that's for sure. Okay, here we go.
And so the next domain is the domain of clinical practice, which covers assessment, therapy, and intervention. And we revamped, although we kept this domain from the previous version, we revamped all the guidelines that belong to this domain. And wanting to, if you haven't seen the previous version of the guidelines, each of them includes a rationale and an application. And once we started working on this section, we decided to kind of change the framework and highlighting different theoretical approaches, and instead of like how it was written before. And that's how we came up with these 4 guidelines. So I'm going to read them as well. So guideline 14 is saying that psychologists empower TGD clients by using a trauma-informed approach. And this is a different aspect that wasn't as discussed as much in the previous version of focusing on trauma. And then guideline 15 is psychologists support each TGD's client's unique journey by using a general affirming and client-centered approach. And in this one, we really wanted to highlight the need to work in collaboration with the client, and one of the areas that we want to highlight throughout, but this is a particular area where we're going to expand that a little bit more, and acknowledging that the client knows best what's needed for them and to work in collaboration. Then guideline 16, psychologists optimize TGD people's health and well-being by facilitating access to gender-affirming medical care. So in this guideline in particular is the guideline they wanted to highlight our working interdisciplinary work with medical care providers and the role of psychologists and when it comes to general affirming medical care. And then for guideline 17, psychologists maintain transparent and collaborative diagnosis, assessment, and treatment planning. And for this one, we do more of an overview of the diagnosis, for example, that are needed to be considered when we're treating transgender individuals. But given that we have to cover a lot of content, we can't go into like specific details for each of the. It's more of an overview of diagnosis. So, and more so in this particular guideline, we wanted to provide more guidance on when it comes to doing assessment, because like there isn't enough information at the moment on how to like apply assessment and work with assessment given so there's not a, this is an area where like there's a lot of research that is needed, and that's reflected in the literature that we were able to review. And then we have our last domain.
So you see what I mean, where it's basically like a whole section about not having that section?
Yeah, they didn't really say very much meaningful.
Yeah, the section is called Assessment, Therapy, and Intervention, and then it's basically saying, don't do any of that and just affirm.
Well, I mean, that's the basic
Yeah.
conundrum that they have, right? I mean, there's no assessment really. So what are they going to say? They're just putting in some bullet points to look like they're saying something substantive.
Yeah.
Yeah. Yeah. And then they spell that out pretty clearly, right? That their priority is to facilitate access to medical care.
Right. Facilitate access to gender transition treatment, but without any assessment whatsoever. That's the clinical practice is just to write. It's just to sign off on hormones and surgeries. It's just yeah. And yet so many people when we try to tell people that this is what gender therapy looks like now, we're like liars, but they're spelling it out all right there. Yeah. Okay.
So the last domain is these two final guidelines, which cover research, education, and training. So guideline 18 is the research-focused guideline. Psychologists take an affirming stance toward TGD individuals in all aspects of planning and conducting studies, including the dissemination and application of research findings in order to reduce health disparities and promote psychological health and well-being. So this is taking into account both the ethics of research and the way that we conduct research. Including considering community input throughout the research process, ideally community-based participatory responses, including starting with the research question itself. Number 19, the final one, is psychologists dismantle cisnormativity in professional training in academic settings and support the full inclusion and professional advancement of TGD psychology students, trainees, supervisors, and educators. So recognizing that as we are all aware, discrimination and transphobia in academia is not a problem of the past. Many training programs do not include much or even any discussion of TGD people, and gender diversity then becomes invisible in our training. This includes considerations of how to best support and empower TGD trainees and educators, including systems-wide change.
All right, thank you for hanging with us for this after lunch portion of afternoon slump. So like we said before, one of our goals is to get feedback. And so as we're writing this iterative process of making sure that what we're writing is reflected in the lived experiences of folks, and that we have voices to say, hey, hold on, are you missing something here? So one of the things that we would love is feedback to improve our work. So we're going to be gathering feedback, taking notes, and so here are some of the guiding questions. Not yet. So one of the things, first maybe I'll just open up with like any thoughts, reactions, questions before we get into some of this. Yeah.
I need to go to another section, so that's why I want to indicate. From what you mentioned and what you revised, especially what you mentioned like the Garcia, there were some direct and indirect implications of advocacy, but I was curious if you ever considered to add another section to discuss what advocacy actions could be engaged in at multiple ecological levels,
Yes.
where we immediate.
Mm-hmm. Yeah, like our different zones of influence for sure. So that is included. We're rewriting and editing right now, and so I'm going to go back and be like, are we including it well enough? But I do think that at least in the minority stress, those four, it's definitely included. Like, how do we actually do this at individual level, interpersonal, institutional, and structural level. And so, yeah, I'm going to make sure that's a nice, strong section.
So that question that you can't really hear, as I understood it, and I'm not sure if you guys could make it out, was basically somebody saying, you know, is there going to be a section kind of spelling out specifically what kind of advocacy psychologists are supposed to be doing? Is that what you guys gathered from that question, or something
I
else?
I think so. No, that's basically I gathered that he wanted to know how was there going to be more advocacy promoted for psychologists to do, in what way. That was what I gathered.
Okay.
Yes.
Hello.
Hi.
My name is Travis.
Hi, Travis.
So I had a couple of questions. So when you are forming guidelines, or maybe this is a general APA guidelines question, how does that impact the Council of Accreditation's accreditation guidelines around what's actually included? I ask because I am a doctoral student. There is like nothing around, like very little around the actual gender affirming care, let alone like the most, what some of the most critical clinical issues such as assessment and treatment. So that's one question I have, like how do you see these guidelines actually interacting with accreditation guidelines, if you do see them doing that? Second, I'm curious where you might fit in, especially given the current legislative climate in which some states are proposing legislation that restricts access to gender affirming care in the case of people who have been diagnosed with a mood disorder, are neurodivergent in some way. How are you putting the guidelines to make it clear that that should not be the case? Like a prior diagnosis of really any type should not be an automatic exclusion of being of a therapist being or a psychologist being able to advocate for someone's gender affirming access to gender affirming.
We completely agree. So there's two pieces to that, right? The first is accreditation, and how are these guidelines used? And I think part of what Rodrigo spoke to, and maybe we can have you speak a little bit more to it. Guidelines for the American Psychological Association are always aspirational, and so they don't hold the same kind of weight that the standards. And so we put them out there. You can see that some of this is like we're really trying to push the field forward, and so they are aspirational. But I do think that they also carry some weight. And so I don't know if anyone else wants to speak to accreditation. I don't know about accreditation.
I don't know very much, but I do know that these guidelines need to take into those conversations when it comes time to revise the accreditation standards, but that is run through a different arm of APA. And so I think there's going to be an importance in the guidelines would be a really strong tool to use to bring into those conversations, but I think as we're looking at updating the accreditation standards, we really need as a community to come together and push to make sure that there are some concrete, specific targets in there, rather than to say, do you talk about diversity? That's not there.
Well, but also because, I'm sorry, because that's my concern. We do get exposure to it in diversity and intercultural process, but that's not treatment, right? So I do not expect coming out of my program that I will know how to properly diagnose gender dysphoria, since we're working with the DSM, and how to do a differential diagnosis in the case of any number of other disorders. And that to me seems very problematic, that it's not part of accreditation guidelines. Like it is a core competency, especially based on the pretty voluminous research that the APA itself has done on psychologists' view of their own competency in these areas.
Yeah, we rate ourselves pretty low, right? And like, thank goodness people are at least a little bit maybe aware that they are lacking some competencies. But yeah, I think I think the idea of this being a tool, I think like Jake said, right? Like I'm hoping, I think all of our hope is that this document gets used in those spaces to say, hey, accreditation, you are a different piece of this puzzle, and like, here are our guidelines, why are you not meeting them? And so I think it's using this as a tool for the next piece. But there was also another question that you were saying, and I lost it.
Yeah, just around including in the guidelines something around access to gender-affirming care.
Yes.
When it co-occurs,
Yes.
or when gender dysphoria co-occurs with
Yes.
any other type.
Yeah, and I think part of what we're seeing legislatively is that it doesn't matter, the American Psychological Association, the American Medical Association, all of the associations can say all the things, and the legislation is just being pushed through. And so I think the other question that we've had that we're talking about is when we call psychologists to these guidelines, and then psychologists who are aiding and abetting folks to access their medical care, like, this is just not, these guidelines are saying folks should be doing this work and providing access and increasing access to care, and yet we still have legislation in various states, some passed, some not, that say psychologists could be sanctioned for helping, right? So I think it's complicated, and I wish they would listen. I don't listen to us, but I do think that there's a lot of problems with where we're at legislatively, and just not listening to the wonderful things like that this is pushing forward.
So I don't know how well you guys could hear that the doctoral student question, but he basically said, I don't feel like coming out of my psychology program, I'm going to have any idea how to do a differential diagnosis or to even assess for gender dysphoria in the first place. And I think that's quite problematic if I'm going to be like treating this population. And is there going to be anything more robust, essentially, in the final version? Oh, he even said, basically, it feels like it's all just diversity training. And then they got back and they're like, yeah, there should be diversity training. And he's like, no, that's what that's what there is, but that's not what I'm needing, And then they continue to not answer the question about having any concrete assessment.
Which was exactly my criticism when I was receiving training to do the hormone readiness assessments was, we had them out twice, and it was a 2-day, basically diversity training, using the right language and the right pronouns and making people feel comfortable. And I'm like, okay, but at what point do we get to be clinicians here? At what point do we get, in on this secret knowledge of what gender dysphoria is? I can learn a secret handshake. Give me the knowledge.
Yeah. Oh, good. They just keep dodging exactly what they're supposed to be.
So I'm definitely not alone in that. I can sense this guy's, he's puzzled by that, right? It's like people who sincerely, and I sincerely wanted to do really good work and really help people. And I get the impression this question, the person asking the question is similar, right? He's interested in doing the work. He's interested in learning. He's interested in understanding what gender dysphoria is and supporting people with gender dysphoria. And he's being alienated from this system of care as a clinician because he can see through this, right? He can see that this is basically just queer theory indoctrination. This isn't clinical information.
This next question is impossible to hear. Well, it's not impossible. You can make it out, but it's painful. The person, and I recall because I was in the room, basically asks, like, and it's clear from the guidelines that what they're lying out. They're outlining like a very specific type of person, right? Like this TGD person is just so unique and interesting and has such a different experience of life. But anyway, so this the question asker is essentially saying, a lot of psychologists feel like transgender people are a completely like alien species just by basically all the rules we know are out the window when dealing with this population. Like all. Like they're essentially along those same lines. It's just another way of asking, is there going to be any actual assessment that clinicians can follow when working with this population? But I think because the question asker said something along the lines of that transgender people are like a special breed, almost alien, that people feel kind of like um, kind of intimidated by working with the population, because it's like it's all these special rules and I don't know what any of it means.
All the special
And
language, and if I get it
yeah,
wrong, someone's going to attack me, or I'm going to lose my job.
right. It's like all the normal, everything we previously knew
To
about,
build
the
bridges
profession.
with people, or to work well with professionals. Let's just make everyone afraid of us, afraid of making mistakes, afraid of having a conversation.
That's exactly what's happened. Yeah. And
Yeah.
that's why so many qualified therapists, when they hear the gender stuff come up, they're just like, okay, go see a gender therapist, because I don't know anything about, because it's like, it's just this whole different world of therapy. And then they go to the gender specialist and it's just these people, you know? But yeah, so they're going to answer that question
Yeah.
about we have no idea how to work with this population. What are you going to give us?
A set of guidelines that I think resolve this. And I think about in practice as a therapist and also published on the interpreter level on so master's level. What I see is folks saying that this requires a hyper specialization and therefore I can so it's almost like the guidelines that it shouldn't be intended to open up the space and make people adapt and essentially the answers to the test to do this practice as well. It's sort of been recognized to say, well, that's a book or that's a specialty that you have part of it. I'm gonna, as a fellow therapist, I'm gonna refer you, but I can't treat trans people because we're so exotic or something, right? So we're like not in the same species. So I'm wondering how notionally or conceptually these guidelines can give people confidence or a sense of that it's everybody's work. So I'm not exactly sure. I guess that's one of the things that comes down to see.
And I don't want to hog the mic, so
Overall, I think it is throughout the guidelines we want to consider like how to incorporate like the community and competency, and I think what we've been told from the first sort of guideline, how they're specifically new, but not only psychologists, that's why we want to, when we're writing these guidelines, we want to take a balance of like, even though it's not only being used by other professionals, but also like it's also being used in different languages. So we want to, even though it's centered in like what the literature in the US, we want it to be as applicable as possible because of what you're saying. Like there are no other guidelines in other languages in other professions. So as much as possible, we try to be able to fill some of those gaps.
Psychologists should be able to treat everyone. That wouldn't say like you're this particular identity, therefore I can't possibly treat you. And I agree with what you said about taking that stance of cultural humility, committing to cultural competency and humility. This is true across any part of your psychological practice. If you can't work with a particular population, you shouldn't be in your field. And that's
There's a difference between clinical and specialization. But to your point, I think we do have a guideline that's going to be addressing psychologists' role and access to care, and hopefully that's going to take that in terms of the range of knowledge and the range of experiences and the realities of where we're at with clinical access to care. So yeah, absolutely, we need specialists. We need folks who have that highest level of skill. But also, can hear that they're saying, like, you're a psychologist, like, step up into the job. Because particularly, like, I work in Florida, and there's only so many people who have so much experience. And so, at some point, you just got that, like, those providers who you don't necessarily have that specialization, when you're picking up these guidelines, your patient that helps you make it work. There's no one to refer them to. So they can kind of actually step off and do skills and find reduction of patient.
So most of that was inaudible, but yeah, the question was essentially, we're spelling out transgender people as if they're a special exotic species that's completely different from the rest of the patient population you would be working with. And so, how are you going to make it so that this working with this population isn't so intimidating and people don't feel so ignorant and out of the loop. And their response was basically like coming at it like the question was about like, how do I work with a Catholic person, or how do I work with a gay person? They're making it all about identity, right? So they're pretending like this isn't us, right? Like there's nothing to treat, nothing to diagnose, right? You just happen to be working with a person who happens to be trans. This is the most important, huge thing about them, but it's really just like this kind of tiny characteristic, as if it's like, they just play it off like it's just an adjective in another identity characteristic, and they kind of do that whole. It's really kind of condescending, like step up and do your job. One of them actually said, like
If they were going to a psychologist for any reason other than gender, I would agree with that statement.
Right.
That being trans isn't the totality of that person, and that's how I would want someone to treat me. Is like, just because I'm trans doesn't mean that we can't just relate to one another as human beings. There's so much more about me. I'm a whole person, and we may actually have values and ideas in common. And so I actually agree with that response if the visit had absolutely nothing to do with gender.
Right, but it's about working with the population for the purpose of writing medication, like healthcare access, right?
Yeah.
So it's specifically about not just about gender, but about medicalizing that gender, and yet you have to pretend like it's just like they happen to be Hindu or whatever.
I think we heard that in another session also, Aaron. I don't remember who's with the psychiatrist, Dan Karasic, I think, or I'm not sure how you say his name, but there was also someone had asked a question, and there was, the idea was that any psychologist should be able to do this, and if they don't want to do it, they should get out of the profession. It seemed to be sort of a widely held sentiment that, stand up and do your job.
Yep.
Yeah. We're not going to tell you what gender dysphoria is so that you have any competence, and then we can demystify this, but you should step up and do your job. I mean, it's very contradictory, isn't it? Yeah. Let's make it as confusing as possible and intimidate you, but tell you you're a bigot if you're intimidated.
Right. But they make it easy to diagnose, right? You just have to listen to the patient and agree with what they say. So it's not really a diagnostic challenge.
True. Yeah, that's true. That's true. If you're going to be as medically ethically devoid as they want you to be, then yes, it is very easy.
Yeah, I identify as someone really muscular with a full, thick head, head of hair. You must affirm me.
That's when I was telling this story on Benjamin Boyce, and he was saying that he identifies as a Giga-Chad, and basically should he be affirmed in that? I was like, according to these guidelines, absolutely. It's and what makes one more valid than the other, as they say. Okay. So this is where I ask my question, which is kind of redundant, but I felt like it was still worthwhile to ask, even though a lot of people had already asked the question about assessment. I found it worthwhile to ask because I could say that I'm a trans person, and therefore I'm supposed to have this special knowledge that they have as well, is the general understanding, I guess. And then I also made a point to draw out that that all of this is based on a fundamental premise that there are trans people and there are cis people, and you're working with the latter of those two, and you need to be able to differentially determine which is a cis person and which is a trans person, because when we're talking about medicalization, that is really important. Anyway, that's just the kind of the foundation, but basically what I was thinking when I asked the question, and you'll hear it in my voice, I'm pretty nervous asking this question because I just knew the tension was going to get crazy, but here we go. So we kind of piggybacked off of the last two questions a little bit, and and also the voluntary phrase there is what are gaps. And this is not like a criticism specifically of you guys, because I've seen it also when I reviewed the adolescent chapter of SOC 8 as well as the mental health chapter. It doesn't really say specifically what those assessments should look like, and I know you said that you're going to elaborate on that, but I am curious what those assessments are going to look like specifically, like what guidelines, like you were saying, you know, like providers need to know what exactly they're treating or what they're looking for to diagnose. And one concern, I'm a trans man, and one concern I have is like, what are providers able to do to ensure that they're not transitioning cis children unnecessarily? That's something that I'm kind of getting more and more concerned about. Certainly reading SOC 8, it doesn't seem to be like, we know that there are trans children and there are cis children, but it's like there's no way to tell which is which. And this also applies to adults as well. Like, I think providers need to have specific guidelines and specific assessment tools to make that differential diagnosis, so that we're not basically treating people as well, gender dysphoria is, and that's, I mean, as far as like for psychological care, right, we should be able to diagnose.
So I think, I'll just speak for myself, it's, you know, I don't know that I speak for everyone, but a part of my approach to trans care is not to treat identities and not to say who's cis or who's trans or who's non-binary, who's gender expansive, but rather treat the dysphoria and the discomfort and the embodiment roles of that person, right? Like how do you want to embody your gender and what's that look like? And so I think that there's a lot in the media right now about like transitioning the wrong kids, and I think there's this undertow, this subtext of it's not okay to be trans, or we don't want people to be trans, or we gotta make sure we're not accidentally transing people. Like, and I think that there's just so much happening right now in the media, and I can't think of the New York Times. Like, I can't. Like, that's just not gonna happen. And so I think the assessment piece though is something that's part of this whole legislative process that people are like, oh, you're not assessing enough, you're not. And I also think that a lot of folks default to over-assessing and over-asking and keeping people in therapy for much longer than they need to be. And so I think there's this delicate balance of, you know, not being gatekeepers, being liberators, getting out of people's way, and also like, there is no assessment. I can't assess my gender. I'm telling you what it is. This is it. And I need you to get out of my way so I can access the care I need. And so, and I also think that there's this piece of like gender exploration therapy or gender explorative therapy that is basically just a cover for conversion therapy. And so, I have a lot of thoughts. I'm happy to chat with you some more about some of that, but I also have to do it.
I mean, what I'll add to that is that when you come, we're very aware of the urgency as well. So even though we have drafted about 2/3 of all the guidelines, we're taking, and like we divided, like we have like divided the work on each of the domains as one little group. When it comes to the developmental, and particularly children and adolescents, we're bringing more of our team members to write it, and we're taking more time because we know the urgency and the care that those particular guidelines need. So that's an area that we're currently writing. So this is what you're mentioning is important for us. We need to consider that writing.
Well, I think it's really important to this name that a lot of the attention around that those sorts of questions, right? Is who's really trans, who's not trans, who's going to start that treatment without really, and then change their mind, right? These are the types of questions that our profession has been asking repeatedly, and somehow even though we're getting results that are showing that the best practice is to trust trans people when they tell you who they are, this narrative somehow continues to replace it in the literature and in the media. And I think the piece that really, the fear that underlies that is this terror of transness. That being trans is unbad, that there's something wrong. Or that there's something wrong with doing a trial of an intervention or a trial of a medication and changing their mind. We do this all the time in therapy. It's a movement. And so the only reason that this is considered more dangerous or more threatening or more negative in the trans community is the transphobic aspect. It is that fear of trans.
So that last speaker is very he's difficult to hear, but he's essentially saying that fear that being concerned that people might be transitioning unnecessarily is just transphobia, because the only reason that you would think transitioning unnecessarily is bad is if you think being trans is bad. It's quite the take.
Yeah, I mean, it bears repeating. I think something that I said in our last episode, that the issue isn't, for me, isn't trans good or trans bad. It's the wrong framing. It's more who's going to benefit from these drastic medical interventions and who isn't. Like, it's not about identity. People can identify however they want, and they can change identity multiple times throughout their lifetime. That's fine. Nobody needs my permission or anyone else's permission to identify as something or to experiment with something, but we're talking about irreversible medical interventions. And just the very dismissive sort of cavalier attitude about, well, who cares if someone chops their breasts off and then later regrets it, right? As if that isn't a severe medical trauma.
Yes.
One thing I keep getting more and more of the impression of, and I did in this room, and it was something that I was concerned about before, that was definitely solidified in this meeting, is that a lot of the people who are writing these guidelines, I think, are people who have already been harmed by gender medicine, and they can't face that, is what I suspect. I tweeted how I put it was, a lot of people driving the gender bus are people who've already been run over by it. It's like, how do you don't, it's not something that you can backtrack, especially when it's not just your body invested in this ideology, it's your profession and your social network. And it's basically, as we can clearly hear, a lot of it's their religion too. I mean, it's their everything. And if one thing starts to fall down, it all comes crumbling down. And I think I think people are going to do everything in their power to keep it propped up. And that's why I think a lot of the people who are now such strong advocates of this affirmation only model are people who've already been harmed by it, and they are not able to face that.
I experienced a taste of that when, like I mentioned in a previous episode, that I'm aware of 3 individuals in Canada who were approved for medically assisted death. And when I mentioned it to somebody in my life, because one of the individuals that I'm aware of was known to both me and this other person. And when I mentioned it to the other person, I was kind of scolded, like, how dare you mention it? How dare you say that out loud? And it really shaming me for mentioning it. We're not allowed to talk about these medical traumas, even if we feel like we have benefited from it in some way. We're still not allowed to just talk about how traumatizing and difficult that experience has been. It's like this unspoken rule in the community that you're never supposed to speak badly about any of these clinicians. You're never supposed to complain about your care. In fact, there was an individual who I know of that had very severe complications from phalloplasty and was having a really difficult time getting appropriate follow-up care and getting it repaired, and was told by the person in the health authority that was sort of the liaison between the surgeon and our province, was being told, well, you should just be grateful that you had this opportunity in the first place.
Wow. That's terrible. Why do you guys think that is the case? Why is that silence so enforced and important? Is it, as you said, Aaron, that the whole house of cards comes tumbling down if anyone digs too deeply? Or
I think so. I think we've created this monster. It's ironic that we're being called transphobic in the work that we're doing with the Gender Dysphoria Alliance, when I feel like this whole machine, this whole monster that's been created, serves itself at the expense of the people that are along for the ride. They're not protecting trans people. they're protecting this system, they're protecting this ideology, and they're protecting the practitioners.
Mm.
And who gives a shit if people are being harmed along the way?
Yeah, that's terrible.
It's quite unfathomable to witness.
Yeah.
In the transcription that you put here, Aaron, I mean, they come right out and say there's something wrong with trying a medication and then changing your mind. We do this all the time in medicine. So I can tell you as a physician, we don't do this all the time in medicine, especially in pediatrics. I mean, you know, I think 2 or 3 times before prescribing an antibiotic or ADHD medication, you know, I mean, we do use medication, but we use it very judiciously. And it is so cavalier the way they talk about these interventions, especially for young people.
Yeah, I mean, I've had medications in the past where, you know, I believe the diagnosis was correct. I believe the medication was correct for the diagnosis, but I was experiencing side effects from the medication and decided not to take it. But that's a very different than, you know, jumping into irreversible medical interventions that will permanently alter my body, that could do serious damage and have a long-term impact with basically no diagnosis.
Right, with no diagnosis.
Yeah.
And Aaron T, I just really want to give you credit for asking that question. That was a pretty difficult room and a tense atmosphere, and you pressed on, and you did, and I thought you did great. So,
Thank you very much.
Especially given your experience of being kicked out of the WPATH conference for asking the same question. You must have been kind of concerned, you know. You tested this theory, right? Like we asked that, what would happen? Because then with WPATH, it was a virtual conference, so it was easy to just click a button and boot you. And we kind of asked, well, what would they have done if you had been there in person? And here's our answer, right? I mean, he must have been worried that bouncers were going to come and actually physically remove you from the room.
Yeah. I mean, I already had gotten from the vibe of the place that it was going to be okay, that there wasn't going to be a huge to do about it, but it was just, you know, I don't like to make things awkward, you know. It's like, and there was, I mean, I'm obviously quite the contrarian, but I don't like awkward interpersonal interactions, you know. And I knew it was going to be the entire room just like, yeah. But and they seemed quite uncomfortable. Like there's a scene, there's a moment when the person who tends to be speaking the most, I think their name is Jay, they're identified as non-binary, where they were very uncomfortable and kind of looked like kind of red in the face as they were answering the question, but then it just kind of tense. And then when they got to, we don't want to be gatekeepers, their face lit up like, oh, he'll agree with me on this. You know, that was how he answered the question. How they answered the question was, we don't want to be. He's like, yeah, we don't want to be gatekeepers. Like, this is this thing that everybody agrees on. We want to be liberators. And obviously, I didn't feel appropriate. But like, no, I do want you to gatekeep, right?
Yeah, and just blaming the media, right? Just blaming this. Oh, there's this narrative going around in the media that's false and it's propaganda, and it's causing people unnecessary concern.
Yep.
Not that there are real detransitioners who are being silenced, and the minute that they talk about their experience, they're, you know, told they're bigots and they're told to shut up.
Right.
So much of this movement is about language, right? It's really and there are these magical words like gatekeeping and conversion therapy that people wield to try to just bring people along or shut people out, you know. But there's so much language, and there's so little focus on what's actually happening to bodies.
Right. Right. That's the crazy, I don't know if it's a paradox or a contradiction or what it is, but it's so infuriating that there's so much hyper focus on words that people use and the tone and narrative, and that's so important, and people are unsafe if you don't get their pronouns right. But then at the same time, the approach to the surgeries and the actual physical harm that's happening, it's like, it's a very bleak contradiction. But as far as it's more like it's entirely about language. This is again something I've been thinking about a lot lately. Is you'll realize that the trans activists and then those pushing against it are basically describing the same instances, the same phenomena, but if you say it in a negative way, the trans activists are saying you're a liar, that's not happening, but they're essentially saying the exact same thing, they're just saying it's good. And so if you like talk about the clinic, right, so Jamie Reed's clinic is a perfect example of this, is that clinic is rushing through and affirming all of these kids, which is exactly what the professionals are telling them to do, right? That's exactly what WPATH is telling them to do. It's exactly what this APA new guidelines are telling them to do. But when Jamie Reed comes out and says, this is what's happening at the clinic, and I think kids are being harmed, they say, you're a liar, that's not happening, that's a good clinic, you know? And it's like those things are happening, and they want them to be happening because that's what the activists want, is no gatekeeping. But when you bring up the actual negative consequences of that, you're lying, and it's not happening. It's just, yeah.
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 You know,
All language.
I think there's a lot of value in you asking the question, Aaron. And I think part of the value, there were obviously other people in that room, and who knows how many who just didn't speak, who are of a similar mind to you. And I think the value in you standing up and identifying yourself as a trans person with these concerns, I think will help reinforce anyone in that room who had any doubt, with what they were hearing, to be able to say, well, even trans people are doubting this.
I hope so. That I kind of had that hope when I went to WPATH, because I thought there'd be a lot more people online who were kind of the same mind. But and I think you might be able to second this, because you were there in person, that the vibe was very much a conference of believers. It didn't seem like there were. I mean, the three of us were there, so yeah, there definitely could have been others, but I got the impression in that room, like the clap, the snapping when somebody was like, I can't remember what it was, but in the just the general vibe in the room, I kind of got the impression that I was sort of alone in this, and there's that guy who's the doctoral student who's asking that really pointed question. He soon in this exchange, he's going to say, what is the APA going to do? Basically, he's asking the APA to make a statement that ROGD is bunk science. So I'm not really sure what angle that guy is coming from, or if he's basically just trying to see if it's bait or something. I'm not sure, maybe, or if he's genuine. I don't really know. It was an interesting character, but his first question was great, and it basically kind of paved the way for the question I needed to ask. But I think the whole being the trans people who are saying this stuff, I think we're doing a lot more of what you describe, Aaron, by the podcast and just other sort of content that we do, because that was another thing. My concerns about asking in the APA session is because there were probably about like 10, 15 people in that room. It was one of the smallest sessions I went to there, so there wasn't a big audience to it. But that also did make my nerves about making myself, public enemy number one a little bit assuaged.
So if there was going to be a gang pile on you, it would have been a small gang pile.
Yeah. But yeah, we're going to see so there's some more responses to it, because they were clearly they all seemed very awkward, and I think you might can attest to this, is they seemed uncomfortable with the question. I think primarily, to your point, Aaron, they seemed uncomfortable that it was a trans person who asked that question, is why they seemed so much more uncomfortable responding to me than they did to the other two, who basically asked similar questions, maybe less pointedly, but
they would have looked really bad. I mean, because the narrative is so much about lived experience and elevating the trans voices, right? So they would have looked really bad just blatantly calling you a transphobe. That was probably a lot of their discomfort, right? Is how do we answer this question in a way that shuts down the question without looking like we're shutting down a trans person?
Right. Yeah. imply the internalized transphobia card. Yeah. All right, let's see what else they have to say about it.
I understand the concern, and I think people are also afraid that how will this be weaponized. And of course, like if there were a way that we could say like, oh well, this kid is going to be racist, right? We wouldn't want you wouldn't want some harm taking place there, but I think there's also some wishful thinking about our power as psychologists and the ability to do assessments that will sort of learn this thing about somebody's the inner part of who they are. And we have a long history of trying to do this over many decades. I actually just published a paper on archival research on this topic on assessment. And, you know, did assessment mean that we had less to pay? We don't know that. We don't know that that's true. And in fact, are people familiar with the Curavel case in Comstock in the UK? And that Curavel was somebody who detransitioned, said in the testimony that the more drugs listeners encourage and you can't be the more people want to double down and prove herself and, you know, say, not admit any uncertainty. Because the conversation wasn't, whatever path you take, you know, we'll figure that out with you. You know, it's okay to be X, Y, Z. You know, and the more that you try to like tell a teenager who they are, right? Like how do teenagers respond to that? You know, so does that reduce regret? You don't have to do it the same as but we do have a lot of data to say that regrets really low, much lower than most repentance. We also have that for informed consent for the past at least 2-3 decades. We've been collecting data on the informed consent model, which is the early 2012 instance. It was out there for the so that model, you know, was observed similarly well. And so, yeah, it is, I do care about that. I think that people who detransition, retransition, or on some different paths should be supported, including with gender affirming care to be at, you know, where they need to be. But the conversation, I think, is nuanced about what best supports that process and how we can make sure that we reduce harm on all fronts.
And shaped by how we're asking these questions, right? So when we're doing research about regret, we're talking to people who do transition, and not the full spectrum of regret. Like I regret that I didn't have access to one of them when I was a kid. That's a regret. And so we're really looking at that full spectrum as a big factor where we're talking about the research and education element, but we really need to start opening this up so that folks who are making these questions are the same people who are doing the same research and
So when you detransition and retransition, I think that the point of your question, right, like how do we ask these questions to increase access to care for folks who need it, right? Like, and I think that is a piece of the puzzle that we can talk about, right? How do we ask questions so that folks know that all the different options are available? What are your embodiment goals? And I think we do have a way as psychologists to say there are better and worse ways to ask these questions, and I think that is a piece of it. It'll be baked in terms of like we're writing these to say there are better and worse ways. It's not going to be a roadmap because each one's going to be pages. And so, but from that guideline, then we can go great. Here are some great questions, right? Here are some not so great questions. That already exists too. And so, like pointing people in the right directions to know how do we help people figure out who they are and who they are for now, knowing that gender is expansive and it changes over time and it's dynamic. Right? Like, there's nothing wrong with that. And there's nothing wrong with that, right? Yes. And like, how do we help people live their best lives?
Also, as a considerate person, that things can change over time. And I've talked to actually kind of a project right now about the process. You know, I would hope that there could be a clinical practice that says if somebody is like, I don't know if this feels right, or maybe I'm going to try this, but I'm scared, you know, change is hard. There's this process of sometimes you make mistakes, you know, and it's okay to say, I'm not sure about this, or like you can slow down and you can stop. But it doesn't mean that I'm going to say you are illegitimate, or like that was a wrong choice and you should throw shade about that. To have that kind of openness to embrace that fear and that uncertainty. That's the part of the experience.
One thing I'll add to that is that the content of the guidance are going to be limited on what's available in the literature because that's one of our criteria was included. So that's going to be a reflection of the literature. But one of the things that we have been really intentional about throughout is that going back to one of the earlier questions is the issue of like advocating and advocacy and the role of psychologists in advocacy beyond our work in treatment, let's say. And for instance, we have changed since the last a version of the guidelines in which they were not allowed to mention the word advocacy. And now we're like very intentional about mentioning our role. And the word, not only the word is about our role in advocating for our clients. That's one piece. The other piece is that, there are going to be some areas that we can't cover because of it's going to be more, in certain areas it's going to be an overview of content, but in addition to the guidelines, we're going to work on having a special issue with the APA journal. That one. So we have a special issue.
It's like all of you to put it together.
That one. So we're gonna have a special issue there where we're gonna be able to expand on some of the content that wasn't being able to make it into the final document. So, and then maybe we'll be able to
So I just want to say that all of that was the answer to my question. So like they all four responded and said very different things. But I did want to point out that again that person Jay, they said that they are a detransitioner and retransitioner, and that it's important to know that gender is that you understand what your client is at that time. Because their gender could change, and we know that gender is diverse and expansive, and then somebody else chimes in and there's nothing wrong with that, and they're like, yeah, there's nothing wrong with that. Like what you were saying, the contradiction of this is both like we need to do this permanent medical intervention on something that is also fluid and ever evolving and expansive, and it changes from day to day, and that's beautiful. And yeah, and they never address that contradiction.
Right. I missed a lot of what was said. I couldn't quite understand it, but I did hear them mention a few times that catchy phrase embodiment goals.
Yeah.
Which, maybe we could talk a little bit about, because that is quite a different perspective, right, than treating gender dysphoria.
Yeah.
Exactly. And I think it all has to do with that whole kind of dealing with regret, or dealing with non-binary people who want to medicalize in some way. They want it's totally being framed away from, the sex change, it's not like that was ever accurate, but as going from one to another, it's just, how do you want to change your body? And how does that relate to your gender identity and expression? And how can this therapist write you the referral to get these embodiment goals?
Yeah. The way I interpreted that this new language of embodiment goals, it really means something different to me. And I think it's a piece that's missing from our understanding. So I think we should link in the show notes underneath is keynote speech that was done by Martine Rothblatt. So anyone who doesn't know who Martine is a American trans woman billionaire who made billions in the technology industry, was a former CEO of Sirius Satellite Radio, and then branched off into medical technologies, and is now developing artificial intelligence technologies with the goal of downloading consciousness into a machine. And was invited to this keynote speech. So at that keynote speech, and this was just a few years ago at the University of Victoria, they host a conference I don't know if it's every year or every so often, called Moving Trans History Forward. And so Martine, and in the audience were people like Jameson Green, Aaron DeVore, so very high profile trans activists. And Martine started the presentation talking about, the concept of gender dysphoria, and that this concept is of, if we feel an incongruence between our gender and our body, that our solution is to change the body, and yay, how successful that's been. And then went off and built on that concept and developed, I can't remember what the term. So this idea, so then she went on to talk about these technologies that she's developing through her organization of trying to get around the limits of the human body in general. So, and was talking about the development of, once they have the technology to download consciousness into machines, that immediately frees us from embodiment altogether. And we could choose any embodiment we want. And so by the end of the presentation, I mean, it got more and more bizarre as she spoke. By the end of the presentation, she was talking about a technology that used nanorobots, so these tiny, tiny little robots, which could swarm together in any shape possible. And that would therefore free us from this embodiment by downloading consciousness into any form imaginable. And she wasn't joking. And, and this is a billionaire with at her disposal, a lot of money, a lot of technologies, it has been involved in high tech and medical technologies, and is quite serious about developing this technology, and is already working on downloading her wife's consciousness into a robot that it has the likeness of her wife. The wife sits with the robot on a daily basis and speaks to it, so that the artificial intelligence will learn her memories and learn her speech patterns and basically become her. I saw a documentary about the two, and they framed it as this beautiful love story that they love each other so much they want to download their consciousness into machines so that they can continue their love story forever. But this is the thinking. This is now in the territory not just of transgender, but transhumanism, about transcending what it means to be human and what it means to be embodied, seeing the body as something problematic and something limiting and confining, and a source of distress and despair and confinement. And so that's how I'm hearing when I hear embodiment goals. I'm hearing it through the lens of where this thinking is going, and pairing with these technologies meant to really free us, in their minds, free us from the limits of having a body at all.
Wow, that's pretty sobering. Thanks for explaining all that. We certainly moved a long way from like discomfort with puberty, to, like,
I know, and it sounds so bizarre, and which is why I don't mention it very often, because it's so, the thinking is so bizarre, and yet this was a mainstream, like local to me, keynote speech at a well-known trans conference with high-profile trans activists there. I mean, Jameson Green used to be the president of WPATH. Wow. And you can see him there in the video asking Martina a question, and they obviously knew each other from their exchange. So this is very much a part of the thinking in trans activism right now, is why stop at transgender? Why not any discomfort or limits to the human body?
There's some kernel of, dare I say, truth in that we're more than our bodies, right? Clearly there's some, whether you come at that from a spiritual perspective or, psychological, we're definitely more than our bodies. And yet our bodies are important. They matter. And our bodies are part of us. And again, back to this, what we've talked about before, about how casually this whole ideology treats our bodies and changes we make to them. And now we're talking about bodies in general. And I'm a physician. I think bodies matter. I think the health of our bodies matter, and they make a big difference in our well-being. And, all the things that we do, like as you talked about what Martine Rothblatt is envisioning for us, I think about all the pleasures of our body,
And not only that, but I mean, they're discovering all the time that we actually, that consciousness isn't just stored in our brain, that we actually, there's a connection between our gut and our mind, or our heart and our mind. I mean, they're doing some fascinating research about how our heart being a center of emotions is more than just a metaphor, that they're actually discovering a science to the relationship between our heart and our brains, and how our whole nervous system stores consciousness, and trauma gets stored in our bodies. Consciousness is in our bodies, and we have the same neurotransmitters that are in our brains in our gut, right? So we're not just a brain that happens to be in this very inconvenient vehicle.
Right, right.
Well put. Carry on.
Yep.
Expand on some of the content that wasn't being able to integrate into their final product. So and then maybe we'll be able to talk into I am coming from, I'm in medicine, but I'm always interested to see how other fields tackle this problem. And we were talking about specialists and generalists, and in medicine, we're trying to reach this at the end of the day. All practitioners and primary care practitioners have some capacity to do some primary care, but we still see the same issue like relegating it to specialists, like the clinics and things like that. And one of the challenges that ends up hurting people who have access to specialty care, which are the same groups over. And so how maybe outside of the context of the guidelines, do you sort of train or re-educate the existing psychology workforce to be able to have that basic capacity? Otherwise, like, unless it takes like 15 years in the doctor, so like, how are we training psychology? Like, what is the time for this change?
Yeah, I think it's a both and. As psychologists, we like to hold this like the dialectic. And I think part of what comes up for me is training our existing workforce. There's no way around it. You can't wait 15 years, right, to create some more doctors who may or may not be a right? And so how do we train our current workforce? How do we train folks to as generalists in gender-friendly care? Everyone should be a generalist in gender-friendly care, right? There are certain areas where you might want some specialists, but that can't be the only place that trans people get health care. And so, like, I think, you know, if I'm going to go have a gender-friendly surgery, I might want a specialist who really knows the ins and outs of that surgery. But if I want to go, you know, get some hormones, I should be able to talk to the doctor and say, yeah, I need my hormones, and then everyone has that. So I don't know if this is pie in the sky for me. I think it's where we need to go. We're not there yet. Like, there's so many doctors who are still just not learning. And so I think it's a training issue. And so I don't know if anyone else wants to speak to.
We thought for some state legislators to implement requirements for certain types of CMS that people have to get. I'm sorry. Yeah, thank you for saying that. All right, this mic doesn't travel. No, I was just saying that there are maybe some mechanisms looking at the state licensure level, again, given, you know, the state of the states, that may or may not be an effective strategy, but definitely in terms of certain types of training opportunities, you can work with the psychology boards and with your state licensing boards to make sure that there are specific CEU requirements that are mandated for all providers.
I love that question, and I particularly love that you asked for a timeline. And I want that question to be asked more. I think, you know, we are able to right now write these guidelines that are by the APA standards aspirational. We're going to put in what is the best practices. You know, we're going to put in what the research says, and we hope people take it and run with it. You know, like whatever advocacy efforts, the APA says that people should be doing advocacy to support their patients to reduce health disparities, right? So, you know, we're gonna write this. It's gonna have the language, and then from there, hopefully, and we know that this is coming out in 2025. So, if anybody wants to be thinking about groundwork for that when the document comes out, hopefully it's used. Yeah.
I'm still going to reiterate, right? Like, our guideline 19 is psychologists dismantle cisnormativity in professional training and academic settings to support the full inclusion and professional advancement of TGD psychology students, trainees, supervisors, and educators, right? Like, everyone needs this, right? And so, but I know you're in medicine, right? So I also know that.
Listen to like psychology, what you all do.
Yeah. Yeah. It's like, write this and then like use it, right? Like, hey, this is from the APA. We gotta make sure that our training program is up to date and that we've got people coming in to provide this training if we don't have anyone already. So I think, yes, I hope it pushes us forward.
So, and even though, I mean, it's gonna take a little while for us to publish this, but it's also important to remind people that the current guidelines are still usable. I mean, you'll see there's some areas like there's not enough conversation about intersectionality of non-binary people, but you can still use those guidelines. And the initial task force also came out with tons of tools in addition to a special issue. I know there's even, I haven't seen it, but I know there's even like videos that the APA put out like that that can be used. So there's that piece. That's one.
Sorry, this is my last follow-up.
It's okay.
Same issue on our side, but like, how do you make it so that, like, what is APA doing as far as, like, are they making CEs score this stuff and then like making it required, or like how do we force the retraining to happen at least on some basic level? And like, if it's not there, what is like political capital that can be expended? Where does that advocacy can go? So like, you already have this organizing body, like they're letting make the guidelines. What's the next step?
I mean, I don't think we're gonna have clear answers to that, but I think someone else asked about accreditation. And that's really important. So we're gonna follow up with them because I mean we're working together with the other departments in APA, but that's something that we actually haven't considered to like the direct impact. So I think that's something that we can definitely. I mean, in this kind of like we wanted to ask people for their feedback because that's something that we didn't consider before.
Yeah, I think in terms of the advocacy, right? Like I would love to see people run with this, but you're right, it's just gonna sit on the shelf if no one does anything with it. And so when I think about the conversation that we were having around like licensing boards and accrediting bodies, I think that's a spot where there's actual, like, to get your license, to renew your license every year, you gotta do some things, right? And like for a psychologist, like, you know, the suicide training, that there's like various trainings, you have to have a certain number, right? There's room there, but that's at the state level. And so, like I know in California, it looks very different than other places. And so, yeah, I don't have a good answer, but I do think the advocacy piece and like how do we take these pieces that are created, that we're spending years to work on, and actually put them into practice, I think, yeah, I think that's a big next step.
I had a question about older. Is there somewhere in the lifespan guidelines something about care partners, other types of living situations? There are some people who guidelines for
Great question. I'm gonna take the next one.
Thank you for that feedback. So we do have a whole section that's on its own going to be about sort of older adulthood. But I think the point about caregivers is really important. So we have one for parents of TGD people, but how can we integrate more caregivers across the lifespan? So thank you for that feedback.
This might very well already be addressed, but I just wanted to, or it was addressed and I kind of just forgot. But two things before I forget, so I'm just gonna say both of them. But can you speak on, I know you mentioned advocacy and like now that you're allowed to use the word everything, but is there wording in the guideline that also encourages like psychologists and therapists to just like stay in touch, you know, with the evolving language, or stay in touch with like, you know, like the political time in the news? I even remember just even across my own like training, I'm fairly career psychologist here, but even in the course of my own training the last few years, how some of the language shifted from like I was never even taught that it was that important to think about it, school and all, but yeah. And then like eventually, just even over time, like it became imperative, or it seemed very imperative to my work. And I'm just wondering if there's language that, like, you know, it really kind of enforces our importance to stay in touch with the communities and the climate. And then the second part is actually still, I think, you know, when Elle was speaking as well, if there's also room for encouragement for like interdisciplinary work in that way, because especially when serving certain communities with the access and disparities and our roles in like all the teaching and the letter writing and everything too. There's more encouragement about like interdisciplinary work, collaboration, and things like that.
Thank you for those questions. So yes, in the introduction, we are going to talk about, because I mean, we have made decisions as well, like we changed the title or like the wording from transgender and gender conforming people to transgender and gender diverse people, and we're going to address why we made that decision, as well as what you mentioned, into kind of like that language is going to keep changing, and we need to keep in touch with that. So that's going to be in the intro. And then for the interdisciplinary collaboration in the domain of clinical domain, there is guideline 16. We have a lot of conversation about this in guideline 16. So that's why we're using the wording specifically of medical care, because that's our way of like kind of connecting the work that we're doing of mental health care to and the interdisciplinary work that is needed with the medical care. So that's the guideline where we're gonna expand. Oh, thank you. That's the guideline where we're gonna expand on that particular collaboration, interdisciplinary collaboration.
I'm glad this slide is up. My name is Ames, my pronouns are he and him, and I am not a clinician, I'm a policy lawyer. But in looking at guideline 15, if there's a way somewhere in there, I'm just putting a finer point on everything that you all said earlier about detransition, and I'm co-signing all that. I think if you had a really clear statement that it's a psychologist's obligation to support people with detransition, that would undercut a lot of the legislative policy that is based on preventing this exploratory therapy that is really representative and conversion. Yeah, thank you.
I appreciate that. Yeah, we haven't considered. I mean, we have lots of different conversations, and maybe it's happening inside conversations, but that's a very important point.
Yeah, I mean the language. I mean, I can tell you right now, the language is gonna, because of the inspirational nature, we can't be like this is the obligatory part. But yes, we'll lead on that towards that. Yeah.
Psychologists should.
Yeah.
So, I don't know if you talked to me before, sorry I can't. But coming from a more like pessimistic point of view, have you considered what are the potential negative responses from the psychologists in general, or specific sections of the APA, or in how can you think about, like, because this is a guideline, and then it is possible that people will say this is the wrong guideline and you shouldn't be doing this, and like how do you prepare yourselves for that potential situation, particularly in the legal climate that we live in?
We're expecting it, and so from the first, we know, and we have access to the public comments from the first guideline. So we know that we actually even got calls already about like the content that needs to be included in all of this. So we know kind of how it happened in the previous guideline, but like things are completely different now and probably worse than before. So we're expecting it, and there's going to be one of the things that you might have missed is that there's going to be different tiers of feedback. So we're going to get community feedback, professional feedback, and also, but there's a public comment period that's going to happen later this year where anyone, regardless of whether they're associated with APA or not, can provide feedback. And usually during that period, we're going to get a lot of that criticism that we'll be able to later on address and touch on.
Yeah, I mean, I think given how many of us on the task force are trans and gender diverse, it's a heavy weight, right, to carry, to move from the 2015 guidelines, which are still existing, which still are there, and everyone can use and critique all they want, and to redevelop them and to recreate them to what we're doing now. I mean, it's heavy work. It's legislative landscape and the self-care that all of us have to figure out how to engage in. I mean, this process is lasting also a lot longer because of all the legislative landscape and the political issues that are happening that we are contending with as people and as professionals. And so we've already gone over how much time we were supposed to spend. And I think it's no surprise that it's in direct relationship to what's happening politically. And so, yeah, we're having lots of conversations about what does this look like as people who are affected by this, who are personally and professionally affected by this. And I think part of the public comment period, I think we've had conversations, I don't remember if we decided or not, that someone else would go through the first draft, take out all the stuff that we don't need to see and hear and give us a little summary of all the hate. I don't want to read all that. That's not good for my mental health. And so, yes, thank you, allies, for going through that for us and reading all the hate and pushing it to the side. And so, yeah, that's a good question, though. Thank you.
So that's a professional who's writing the APA's guidelines for working with transgender patients, and they just said that they're going to have an ally read all the negative comments during the open comment period and push them to the side so that they don't have to read the hate.
I guess it's hard to know what they mean by hate. If they mean like personal venomous attacks, I guess I could understand that. But if they mean gender critical comments, that kind of flies in the face of what they said earlier, right? Like, we welcome anyone to make a comment and express their opinion. We really value your feedback. So hard to know maybe what they meant by that.
Yeah. That was kind of, shocking when I heard that. It's like during the open comment period, it's like only the praise.
Only comments that agree with what they're already saying will be allowed to make it through.
Right, to even be viewed by them. What's the point, Yeah.
I think also, we're integrating what is in the evidence base. We are scientists, and if there is something that is in the evidence base that needs to be included, great. But we are not politicians, and we are not going to just say like, well, this is like the political climate XYZ. We're going to include the science. Yeah, and that in some ways makes it a little easier.
And being critical consumers of the science, because we also know that there's a lot of science happening right now, especially in some journals that are pretty problematic. And yes, thank you. Yes, sometimes.
I mean, and so I'm sure like during the comment period, we're gonna get like some links to certain probably more like online news articles that people might want us to cite, but we have very clear criteria of what we can include based on science. So even if people, and when it comes to the public comment section, we need to respond to that, and doesn't mean that we need to incorporate everything that's being suggested, but we need to respond to it. So we'll be able to respond. And we're also going to publish a paper related to the process of writing this, because we want there to be as much transparency as possible about the decisions that were made and how we came out with the guidelines. So, and we have a very clear criteria of what we can include or not. But it is true also that as much as it's based on science, we're not putting our opinions in it, but we are also bringing not only a scholarly experience, but experiential, like Dr. L told us in the morning, reminding us that we're also bringing that into this, and that's why sometimes it is somewhat personal, but we're keeping this center on the science.
So one, I don't remember who was on the earlier slide. What is actually the process by which this gets ratified? I think you described like the public comment or the levels of comment, but who does this have to go through to actually be adopted by the APA? First question. And then second question is actually on that prior point, are you going to talk about in these guidelines like pseudoscience that needs to be discarded, such as rapid onset gender dysphoria, frankly, bullshit that I hear, again, people quoting in my program, and I have to be the one as a student saying, actually that paper, the revision on that paper was longer than the paper itself and didn't actually talk to any trans people? Like, are you going to include things like actually like pinpoint this is pseudoscience, this needs to be disregarded from a scientific perspective? Because
Yeah.
With RLGD, we know the archives of Pennsylvania is made across Illinois, but it's also this spread of trans research that is like sort of validating it by responding to it, which I have talked about and want to reiterate. But how, like, is there an obligation? Like, in your public phase, they're going to cite public consumers of science are going to cite these things that are published. Archive is like one of the highest impacts tool and possible. So like how do you decide to respond to it or not because it's being weaponized in legislation now and because big names within our field are implicitly validating it by extending its time in the spotlight of these recent things?
So the guideline we're just going to be covering is the guideline 18. And one of the more about like the role of psychologists, the ethical role of psychologists, and especially when it comes to research. I doubt that we're gonna name specific journals. I don't think that's gonna be approved.
I wasn't saying
not specific journals, but specific hypotheses that are gaining traction and are not scientifically sound.
This is an ongoing conversation that we have. We're gonna name we're gonna bring up. There's gonna be a discussion about that. So there will be. The extent of what is approved ultimately we'll see, but we're definitely gonna bring up like the need to the role of psychologists in not only advocating. The guidelines have been written in a form that everything that is included is gender affirming. We're taking a gender affirming stand. So and based on science. So anything that is not, even if it's been published and is in peer review and is not gender affirming, we do have to acknowledge it, but also acknowledge how it goes, it doesn't contribute to our we're gonna critique it because it doesn't contribute to the extent that we have taken throughout each of the guidelines. So so that's one way, one of the an answer to one of your question. The other one is the reality is that we're gonna finish writing the full draft by August probably, but as we mentioned, this is not gonna be published until 2025 most likely because it's gonna go. We're expecting to go through multiple rounds of revisions. So ultimately, APA has to approve it. But before that, there's going to be we want to get feedback from the community. We want to get feedback from external professional. We want to get feedback from the public. So it is going to go through multiple revisions.
Yeah, I guess, but my question is not about the revision process; it's about the approval process. Like, what is the approval process?
I don't have with me. I can share that. There's we have a timeline that includes all of that, but ultimately there's multiple bodies on APA that are going to be involved in the approval process. They also have to go to different stakeholders, including the legal team, and so ultimately it's going to be, and then they're going to come back to us about we're expecting this because we know what happened in the first one, some of the language that can be included. The example that I used earlier was even the word advocacy was something that was not approved in 2015, that now it will be. So we're expecting some of that to happen. So that's where our timeline includes some of this enough time to be able to address that as well.
I'll just add that APA has tasked us with creating this, so it's not like we're creating this and hey APA, will you accept it? So they have put us together, are giving us the staff support, all the support that we need to create them. I think the revisions upon revisions upon revisions and legal counsel and everyone approving are those final steps, but we have been tasked to create them and APA wants us to create them. I think the finer points are what words can be included, how exactly things like advocacy get included or not are more of a question at that ending point, but APA has tasked us to do this.
And I just wanted to say, we are trying to be thoughtful about how to deal with when people put things out as if they are psychiatric diagnoses that have a large evidence base and that they're not. You know, do we talk about it more to give it more airtime? This is just, you know, honestly, I'm looking for feedback from you all. So if you have thoughts on like what you would personally like to see in a guideline, that would be helpful. How to balance that, not giving it too much airtime to sort of legitimize it more, even though somebody might be talking about how it's not a psychiatric diagnosis, or like here's the sort of context or the methods for how people wrote those articles. You know, I think it's a fine line to walk. And it's not just the guidelines group that's thinking about this right now. APA put on their website, there is a working group for what's going on with trans youth, working on doing a review of the evidence base that is sort of working to address that as well. But yeah, and I do think, you know, if people are members of APA or other professional organizations and want to make their voices heard, to say like we need responses to this and your thoughts about how you would do that. I mean, yeah, like right now, later, you know, open to hearing it.
I'm so sorry.
Go for it. This is kind of the whole point of the session.
So my perspective from sort of the point of view perspective is that these guidelines are important in setting a cultural standard, but don't have much power in terms of really no power in terms of enforcement. Which means that, in my opinion, the negative statements that you make are probably even more important than the positive statements that you make, because those are the things that you can take a stance on without forcing anyone to do anything. So actually, maybe I understand your point, Dr. around not giving things more airtime, but to me this is probably the most important place to say the APA does not, in its considered scientific opinion, does not view this to be legitimate science. Like that will carry, in my opinion, a lot of weight, because, you know, in a lawsuit or something, no one can say, no one can point to this document and say, you didn't give me this care because it's not a standard. But they will be able to say, the APA has explicitly said that this is not best practice, and that is very powerful.
As far as strategy, like, I want to clarify, I don't think, so it has a rotten foundation. R.J. Restar and Florence Ashley wrote comprehensive and perfect critiques of why the original paper was nonsensical. Those are, we can stop anything that has come after it on the basis of that paper, or based on the ROGD, is trying to develop a theory that is founded in a bad article. So my engagement, I get to talk to some NPA students on evidence to talk about this whole case. Is it's created for you. Just write the paper and start the two bi trans people why, not taking a bias stance, not talking about supporting transness for no reason, but just saying like methodologically this is not sound. And just leave it there. Your response to like strategies for how, instead of extending beyond the 5 papers that Jack Turban published in every journal, and this new one that was basically somebody like, mom just saying I hate trans people in archives. Don't address those because they come from a poisonous root.
Yeah, I appreciate that approach.
I did just want to say, if you haven't seen the CAPS statement in response to RGD, a lot of professional orgs signed on. Did APA or did 44 sign? I feel like did 44 did. Okay, so that is. Oh my God, I'm so sorry. Division 44 is the division of the APA that's for the psychology of sexual orientation and gender diversity. So APA has different divisions, but you know, if an APA division signs on to something, you can say like this is something that, you know, an APA division is signed on to. So in the meantime, you know, that's an important document to be aware of.
Oh boy.
Sorry, I realized you were trying to signal to stop, and I was like, "What is he
It's
doing?"
okay. It's okay. I just wasn't sure how much more of that I could stomach without jumping in and defending Dr. Lippman. And so they're obviously referencing two papers. They're referencing Dr. Lippman's original paper where she developed the terminology rapid onset gender dysphoria and a hypothesis of social contagion, and referencing Dr. Bailey's recent article in a Springer journal, which offered sort of further investigation into the ROGD phenomenon that's been now retracted due to activist pressure over a technicality on his methodology. And yet, so basically, where do we start? Basically, they're ripping apart any research that doesn't fit their narrative as pseudoscience, but they don't seem to mind that every shitty paper that Jack Turbin churns out based on a single survey data that's a very flawed data set, and he turns out paper after paper after paper using that flawed data set. But because he's churning out basically they're activist papers churning out a narrative using this false data, they don't seem to mind that actual pseudoscience. They're very keen to discredit this idea of rapid onset gender dysphoria. But one thing they said in there was that it's this false psychiatric diagnosis. And I want to clarify that Dr. Lippman did not intend for rapid onset gender dysphoria to be a psychiatric diagnosis. It's not, she doesn't intend for that to sit alongside gender dysphoria in the DSM as a separate or a subcategory of gender dysphoria. She coined that term to refer to a social phenomenon, not a psychiatric diagnosis. And I just hear that over and over and over again, that she's created this false psychiatric diagnosis, but that was never her intention.
Again, it's back to the language. They want to get rid of the term because then they can discount the phenomenon. They're clearly not interested in discussing, well, what is going on with these young people who didn't necessarily have any signs of gender dysphoria prior to puberty. And most of them are girls, and all of a sudden it's a skyrocketing group that would rather not be the sex they were assigned at birth. And so what's going on with that? They seem to lack any curiosity at all. All they want to do is banish us from using the term.
Yeah. And yet trans people, like, on YouTube or all over the place, use terms like trans trenders and these different terms to reference basically the same phenomenon. I think the community knows full well that these trans trenders exist. It's just that Lippman is now kind of studying them, and rather than calling them trans trenders, is calling them ROGD, but the community knows full well that these people exist. And I remember when our conversion therapy law was being debated in Parliament here in Canada, I got pulled into a conversation on Twitter with a very high-profile trans activist in Canada who admitted to me that she spent a great deal of political capital on getting that law written and passed. And in that conversation, we were talking about, this cohort of young people who have adopted, this queer theory way of thinking. And they're the ones, with the blue hair and the piercings, and this subculture, youth subculture has developed. And in that conversation, she admitted she knows full well that they exist and that that's happening. And her advice, when I said, well, parents are concerned about those kids. Parents are concerned when those kids are adopting this subculture and then are actually getting hormones and surgeries. And this trans activist told me those parents, she said, it's no different than flower power, and those parents should just roll with it.
Wow.
I kept screenshots of that conversation. So these high-profile trans activists know full well that kids are getting wrapped up in this queer theory bullshit and are accessing hormones and surgeries who have no gender dysphoria at all whatsoever. And they're being told, just roll with it, because these parents, so I said, well, are you willing to say that to an actual parent? So I pulled in this parent that I know whose kid got caught up in that subculture, has since desisted, has no, is completely moved on from a trans identity, but came very close to being started on hormones, because when they took this child to, I think it was Sick Kids Hospital, they were willing to start medical treatment on the spot. And and they felt that was too fast. So they said, well, we want more time to think about this and process it. And then the kid just moved on from that identity. And so I pulled that parent into the conversation with this activist. And I said, well, you tell this parent to their face that they should have just rolled with it. And this activist basically told the dad that they were a bigot for not affirming their kid.
Wow. That's
So
just
it's absolute willful ignorance that this is happening to children. And, you know, we can't blame parents or other concerned people who see this phenomenon happening. We can't blame this, you know, this backlash on the trans community when trans activists are willfully, blatantly, openly just ignoring that those children are being harmed. And it goes back to what I was saying earlier, that we're protecting this machine that has been created. We're not protecting individuals, including trans people, who are going to experience a huge backlash from the amount of children that are being harmed by this.
That's right.
Well put. Well interjected too. I was like, how are we going to tackle every bit of this this Littman assault? But you handled it all. Nice. All right.
And there's just, I mean, just a quick thing about the methodology of both of those studies, Littman's and Bailey's. I mean, there was nothing unusual about their methodology in other areas of scientific research, medical research, you know, mental health research. Talking to parent and getting parent reports on different symptoms that they're seeing and observing. None of that is unusual in research. So there was no methodological flaw in the research.
Yep. They just have to shut down any attention to it.
Yeah.
Time, you know, that's an important document to be aware of.
I like this. Hi, Elliot. Yeah, just to address your point, you know, what does APA do that actually does have teeth? Not a whole heck of a lot if we're being just honest, right? We're not a licensing board. APA is not a licensing board. APIC is the one that kind of enforces our accreditation standards for the most part, right? So what the point of the guidelines is that kind of aspirational piece. But, and again, I would encourage anybody who cares about this issue deeply and as a psychologist to contact ABA, is that we need this resolution. We need this resolution because that is the type of document that is really structured to address exactly what you're saying, is that, you know, we don't do this. This isn't right.
But I guess I just want to push back on that. The APA does have a lot of power, and that's why the first question I asked was about the Council of Accreditation.
Yeah.
Because that is where the power of the APA lies. You are able to determine the APA through the COA, which is technically, you know, semi-separate from the policy body, it is able to deem legitimate doctoral programs, internships, postdoctoral. That is a lot of power, right? And it's able to say you are not a legitimate accredited educational program if you do not cover certain things, right? So that is a huge amount of power, and then all of the state, well, maybe not all, but a lot of state licensure requirements point back to the COA requirements. So I actually don't agree with you. I think that the APA on the policy side, I agree, does not have a lot of power. All of the power, in my view, lies in the accreditation council.
You're absolutely right.
I mean, this is more from personal experience, but we haven't really worked closely with the accreditation side of APA. But from my doctoral training, it seemed to me that there's more focus. There is obviously, in order to get accredited, you need to have like a focus on diversity, and there needs to be more emphasis on race and ethnicity, and then everything else is a little more like leeway on what counts. So a lot of things get approved. So I do think we need to be more clear on what needs to be covered for that to be approved. So yeah, I agree with that. With you.
I also think the resolutions are there's a resolutions there's two specifically that I'm thinking about on not having sexual orientation change efforts or gender identity change efforts, and those carry even more weight. You know, these are aspirational, but those resolutions say this is what, as a governing body, as an APA, that we are saying yes or no to. And so I think that's where really coming back to a resolution on what is the current state of the research and how do we support trans kids There are a bunch of folks who got together and wrote some things, and I hear it's awesome. I haven't seen it, but I don't think we will see it because it takes us so long to get through legal counsel.
But if you would like to see it and are a member of the APA, feel free to ask them.
For the draft?
No, I mean to get it through.
Oh, to get it through.
Oh, yeah.
But it's how, like the process of doing
A resolution to the APA?
no,
Emailing her.
of supporting that condition. Then we need to know the name, the number, the.
You know Ron? Larry?
Counselor?
I
Yeah.
think you can email. Like, you can-
Well, I
If
think.
you can email, like, you can email that you can contact it. You can put it in the
Contact the APA president.
I mean,
really, she just responded the other day.
she did, yeah. So I think just saying honestly, what are your concerns? What do you need the APA to address? So what's going on for you? And if that overlaps with efforts that are ongoing at the APA and can, grease the wheels a little bit, just saying like, or like I work with youth or I work with trans people, I'm concerned about this, I need guidance around this, you're my professional organization, please put something forth and create some momentum to respond to these concerns.
Hi there. This is a little bit of a deviation from the focus here, but I've heard in a lot of the different panels that gender exploratory therapy is essentially conversion therapy. Can you I think maybe I don't quite understand what gender exploratory therapy is, and I'm wondering if you can maybe describe it.
Yes, the question, I realize that we're having some noisy neighbors. Hoping they're having a great time. The question was about gender identity change efforts, or like gender exploratory therapy, and like why that is similar, or how that is similar maybe to change efforts.
Yeah, that it's been described as essentially a different way of, a different word, right, for conversion therapy.
So before gender exploratory therapy kind of became a catchphrase, we had therapy that was for the exploration of gender, including with youth. Exploring your gender is not a bad thing. And I just want to say that very clearly. So, there's I think a difference between sort of open-ended, like, what's your journey? What's your process? How are you learning about who you are? What are you finding makes you feel more comfortable? What doesn't feel right to you? Versus what's sort of, we're thinking way back to like Sandor Rado and psychoanalysis and conversion therapy. This is discussed really well in a paper by Florence Ashley, Interrogating Gender Exploratory Therapy. And I recommend reading it. So thinking about the history of that. So what is a gender identity change effort? And how do we distinguish that between open-ended exploration? And so conversion therapy is we come from a basis of differences pathological. So to be queer, to be trans, etc., is a bad thing, or an outcome we don't want. And so, in that paper, Ashley discusses, okay, does therapy stop if somebody identifies as cis, and why is that? Is the goal really to see that if somebody could be cis, could we encourage somebody to be cis and say that that is better than being gender diverse in some way or being trans? That really, it's really actually fairly simple, I think, in some ways, to sort of differentiate that, to say, is this an open-ended process led by a client? And I'm not saying the client is making all their decisions if they're a minor, right? This is in collaboration with like physicians and caregivers and things like that. It's an iterative, long-term process. If we're talking medical intervention, that's not what I mean. I mean, when you're in the room with the therapist, is the therapist saying, this is who you should be? This is a better way to be? Being gender diverse is wrong, or it's less good than being cis? Or is it about like any way that you could be is fine? Like it's okay to be gender diverse in all these different ways. And is it about like discovering who you are in this joyful way versus I am going to sort of interrogate you to figure out if there's a way that you could be cis instead.
Watchful waiting.
like the Amsterdam model.
Their goal is to find a path that prevents you from doing medical transition. Like, it's like the therapist has a goal and what you do. Sorry.
Gender exploratory therapy. It's one of those things where it was, I think, cleverly named and cleverly coined to confuse people to think that like therapists are encouraging exploration of gender. So this thing called gender exploratory therapy must be supported by them, must be good, but it's not. So it's kind of, I view it as very clever, like evil, clever marketing, because it is different than exploring gender versus this thing that they
arguing with the gender affirming model.
Yeah.
Right.
So that's kind of, I think, where the language and the semantics can get really confusing and really insidious in some ways.
And I mean, yeah, you don't have to sort of take our word for it. I think if somebody reads, they put out, not to say that I think everybody should be reading these manuals that aren't necessarily evidence-based, but if you do read the Gender Exploratory Therapy Manual, like at a certain point, you're noticing like, interesting, like there's this sort of assumption of pathology. All therapy is exploration.
Gender exploratory therapy, to me, there's something hidden in there. And not even hidden, but what's baked in there is hidden in that we're going to get you when you're 6, or we're exploring until we find out you're 6, and that's actually too. That's what therapy is.
So, personally, like working for a system that we're always trying to establish policy and procedures, I find this very helpful on a much larger scale because there is not something so comprehensive from what I've seen that exists for providing behavioral health care. So, just overall, I think it's really helpful. What I'm curious about is, obviously, only a portion of folks that provide behavioral health services are psychologists. So I'm just curious if there's already efforts in how this then intersects with social workers, therapists, etc., who are also providing a huge amount of the direct service to folks, and how we can, as not psychologists, because there's a lot of talk about how psychologists can support this. What is like a collective way, right? That because I think we all have the same goal. So I'm just curious if you have any thoughts on that, or.
So we are writing this with psychologists in mind because we're writing for APA, but we're very well aware that these are being used by other disciplines as well. So like we've been told by the first iteration is being used by social workers and as I mentioned earlier, not only by different disciplines but also different countries. So even though this is like based in US based, it's being used for other places that there's no guidance. So it's been so we're keeping that in mind as we write it, so it's applicable to other disciplines as well. And I think with that, we want to thank everyone for coming and all your comments. Thank you.
And we are available. I will also note we are available. Feel free to find any of us. Email us if you have other thoughts that come up. Or like, hey, how can we get this into the guideline? Like, just feel free to be in contact. Thank you.
Well, I feel like we need a new term to express what gender exploratory therapy is meant to do, because that's become, sort of forbidden to use, like ROGD, right? Again, another phenomenon that we can't describe, so when that question was asked, the first person from the panel who responded actually sounded pretty reasonable in a sense, like, yeah, there's room for exploration, ask questions. What does this mean to you, your gender? But then in reality, what happens is gender affirming care, right? And then another audience participant said, oh no, I think of gender exploratory care as, what did they say? Evil marketing, an evil marketing term. So in fact, there's no exploration with gender affirming care. It's just, what do you think? What do you feel? Who do you want to be? Okay, great. That's it. So where is is there another term we could use? Like, could we, and it's like gatekeeping, right? It's in that same category. Like, we need new language to say what's really going on. Like I envision like therapists holding a person, especially like a young person, in this holding space, and so instead of gatekeeping, is it that you're actually prematurely ushering them through a door that they shouldn't go through, that they won't be able to go back, like we need a new vision somehow, a new way of expressing what's happening, because these words are just things that people just immediately react to when they close their ears.
Yeah. It's funny because at the same time that they're always reinventing new words to mean things, they're also, when it comes to gender affirming care and those words, what they've actually done is they've changed the meaning but kept the words. Because, back when Dr. Laura Edwards-Leeper brought gender affirming care for young people to North America, or to the United States at least, it meant something very differently back then than it does now. So what they mean now, and this is why it's so frustrating, because there's so many different meanings for these terminologies, and then we're debating based on how we interpret those words, but different people in the debate might be using those words differently. So what these activists mean by gender affirming care, I think, is better described as the informed consent only model. Because the gender affirming care in its original form was about exploration. It just meant that it meant that that the therapist still had a supportive stance, that they didn't see transition as an awful outcome, but it didn't mean confirmation that they actually had gender dysphoria. So it was about building a relationship of trust and rapport with the client, and not immediately saying, well, no, what you're experiencing is bad or awful and needs to change. But there was still thorough, comprehensive assessment, exploratory psychotherapy, and an exploratory approach before medicalizing young people. So that's what gender, and so really gender exploratory therapy is really just a new term for what the affirmation model used to be, because activists have completely changed what gender affirming care means, but they're still using that term. So we had to have another word or another term to describe an exploratory approach, because gender affirming care no longer means exploration. So it just frustrates me in the public debates when, the concerned public is using gender affirming care to mean no gatekeeping, just immediately medicalize anyone that wants these interventions. So that's how they're using gender affirming care. And so it's becoming so messy, because we're kind of throwing mud back and forth, but not agreeing on what these terminologies mean. And I think we need to kind of dump some of these terminologies and just be very clear and specific about what we're talking about is medicalizing young people with no assessment, no exploration of their identity development and how they came to this conclusion. And that's what we're talking about, right? And that's what we're concerned about is the elimination of any kind of safeguarding or diagnosis or safekeeping, as Buck Angel would say.
Right.
So so that's why it's so frustrating. These activists are saying, no, we support gender affirming care, we don't support exploratory therapy. It's like, well, gender affirming care used to be all about exploratory therapy. So they're demonizing something that used to be a part of the care that they say that they support.
And they've kind of, a trans versus cis identity.
Yeah, and you made a good point in a previous episode, Aaron, that basically they're substituting. It used to be gatekeeping was the dirty word, and now they're calling it conversion therapy. And I think they mean the same thing, right? It's
yep.
Gatekeeping maybe wasn't strong enough a word for them to use, and now they're calling it conversion therapy.
Right. And so they think, do any attempt, and they're very clear, like that's what they meant there. It's like any attempt to find out where these gender feelings are coming from is an attempt to change a trans person into a cis person. So it's a change effort, when really, obviously, that's not at all what's going on. But they have to reframe it into their that dichotomy that they need.
Yeah. And the way that our conversion therapy laws, and I think a lot of these conversion therapy laws that are popping up are worded in a similar way. Ours is worded in a way that says, basically any attempt to change an identity to cis. So what does that mean? I mean, does that mean any attempt to make a pedophile not a pedophile is conversion therapy? Does that mean anyone that identifies as a frog or a cat gender or a cake gender, that any attempt to these exist, these new gender cake gender does exist, frog gender does exist in this youth subculture. So any attempt to change, to tell, if I were to say to a young client, well, you're not actually a frog, that's conversion therapy, according to how these conversion therapy laws are written, because that would be, trying to change someone's gender identity to a cisgender identity.
Yep. But the words all just sound so good, so it flies under the radar.
Our conversion therapy law, thankfully, does have a clause that says it basically excludes the assessment process leading up to medicalization, and it excludes an exploration of someone's gender or their identity development. So
it explicitly says that?
It explicitly says that. So we do have a clause that protects exploratory therapy, but the activists in Canada are working really, really hard because they didn't get their way with the wording of our bill. Now they're working really hard at professional associations to try to say, well, no, I mean, any exploratory therapy is also conversion therapy. So they're trying to get around the legal. I don't think it would hold up in court, because in court you have to go by what it says in law, and we have that exclusion clause. But if they go after the professional bodies, people could lose their licenses if they convince the professional bodies that any exploration of someone's gender is conversion therapy.
Wrap it up. We've been at this 3 hours.
Yeah. Great conversation. Thank you to you both.
Thank you to you both.
Thank you. Thank you. See you next time.
See you later. Bye-bye. Take care.
Thanks for joining us for this episode of the Transparency Podcast. If you enjoy our content, please help out our algorithm by hitting like or subscribe. If you'd like to make a donation, follow the link to our PayPal account. On behalf of the Gender Dysphoria Alliance, thanks for your support.